Ready? Yes. Okay, we'll call the meeting to order. It is Enforcement Committee of the State Board of Pharmacy. Do a roll call. Stan, would you like to start?
All right. Stan Weiser, professional member.
Amy Gutierrez, professional member.
Alan Shad, professional member.
Ricardo Sanchez, public member.
Greg Lippy, public member.
First item on the agenda is public comments for items not on the agenda or agenda items for future meetings. Is there anyone from the public that would like to come up and provide comments? Good morning. Happy New Year.
All these mic working?
Yeah, make sure the green button's on so that we can hear you.
Can you hear me?
Yes.
Okay, great. You've all got my prepared statement in front of you. I'm Jeremy Schmidt. I'm with Roadrunner Pharmacy. It's a pharmacy located in Phoenix, Arizona that deals exclusively in the veterinary
What is your
industry.
statement? Is it
It was a one-page
is it this
statement
one?
that was handed out.
This one.
Okay. It says California Board Response?
Yes.
Okay.
Yeah.
Thank
so-
you.
Yeah, so we work exclusively in the veterinary community. We work with over 23,000 animal clinics nationwide. That's nearly 2/3 of them. And my company has come up with this response to the new BUD dating regulations. So I'll just begin with the letter. With the passage by this board of new restrictive testing and beyond use dating requirements that become effective 2 days ago, the compounding pharmacy and veterinary community has been negatively impacted for patient care. The primary reason that veterinarians require longer BUD dating is because they practice differently. The board has responded appropriately earlier when new office use and dispensing regulations were adapted to accommodate veterinary practice. We all know that when you take your pet in to see the veterinarians, one expects to leave with the appropriate medication. This happens from compounded office stock on an ongoing basis. The new testing requirements for additional stability for products that have been sold for years will result in an added financial burden to every pet owner in California. Many pharmacies like our own have up to 300 lines of non-sterile medications that practices need daily to treat these pets when they walk in. The newly required testing can add as much as $30,000 annually per medication to meet the new board requirements. The veterinary medication market is so small that these added costs over a few products will drive pet owners away from the veterinarians. The other option of 14 days dating does not work. Many medications made in our pharmacy are routinely tested before release, leaving only a few days for veterinary practices to use. They'll also only purchase a tiny amount, yet shipping and testing must be spread over the company's costs, inflating these prices of these medications substantially. We ask that veterinary medications be exempted from these added testing requirements. Pets are not people, and our pharmacy has demonstrated over a 20-year period that our potency stability testing has been effective and adequate for a national pet population. Reducing medications to treat your pet in California by reducing availability and/or driving up price 2 to 4 times for pet owners is not the answer. At a minimum, we request the board place this item of concern on the agenda for your next meeting so that we can address these challenges with the veterinary community input. Given the service-on-demand nature of veterinary medicine, the office use requirements are unable to give an accurate assessment of realistic office use needs. Again, we ask for your consideration for an exemption for veterinary practice.
And this is for non-sterile, just a point of
Yes,
clarification,
correct.
not sterile.
We're talking, I guess, mainly about the aqueous formulations that have a 14-day dating now.
Like oral medications
Hmm.
and topical.
Oh, I believe topical is given a 30-day expiration with the new regs.
Thank you.
Thank you.
Can we put it on the agenda for ledge rag or for here? Where should it go?
Sorry. It would probably be a compounding matter, so it would be the later part of future agenda
Okay.
for this committee.
Okay.
We require, because of the notice requirements, we need to have an item on the agenda to have
Right.
discussion.
Right.
So we'll have to put it on the agenda for the next meeting.
Okay, great.
Okay.
Sounds good.
Thank
for
you.
your time. Appreciate it.
Thank you. Any other public comment? Otherwise, we'll move on to Cures 2.0 Prescription Drug Monitoring Program. We're fortunate to have Mike Small here from the DOJ, who's going to provide us an overview on the new Cures 2.0 program and where we are. Mike?
Thank you and good morning. Before I get started, I'd like to mention that both the DCA and DOJ have jointly announced, as of yesterday, the intended decommissioning of Cures 1.0. to occur March 5th of this year.
March 5th of
Yes, March 5,
2017?
yes.
Do we know how many users have not migrated over?
It's fewer than 10%, so,
About 15,000, isn't it?
yeah, that have not,
Pharmacists?
it's,
We don't know how many because they haven't identified what their status is.
yeah, it's roughly 13,000.
I said
That have not signed into the new Cures 2.0 system. So it's a relatively small amount. And
When they sign in, will they be directed to the registration for 2.0?
Well, they will get a message that they will not be redirected. They'll get directions that they have to go to Cures 2.0 on a acceptable browser. Because presumably, if they're still using Cures 1.0, it's because they're using a version older than IE 11. And we can't support that on Cures 2.0. So there'll be instructions on, obtaining another acceptable browser and then how to sign on. So, and their accounts are, of course, valid in 2.0 already. It's just they just need to sign in for the first time. Yeah. So with that, I'll move on.
And we have copies of your slides. It's in attachment 1 as well. Problem.
Okay, as you know, Cures is the state's prescription drug monitoring program. All dispenses are required to report all Schedule 2, 3, and 4 dispensations to DOJ within 1 week. We are currently getting over 1 million scripts a week, and we consider the dispenser to be the originator and owner of that data. DOJ does not add, modify, or delete that data, does not touch it in any way. In fact, I have to be prepared to go to court and for adjudication purposes and testify that I don't touch the data. That's why if a prescriber or a patient is contesting the validity of that prescription report, we'll recommend that person confer with the pharmacist and make a determination whether that ought to be changed. The pharmacist is the only person who can actually change that record. We provide both dispensers and prescribers with a patient activity report, in other words, a history of the 2, 3, and 4 dispensations for that patient of up to 12 months. All licensed pharmacists and all licensed prescribers who are authorized to prescribe controlled substances are required to be registered to access Cures now. And SB 482 that was just passed in this last session adds Section 165.4 to the Health and Safety Code that will require prescribers to consult the database prior to the first time prescribing of a Schedule 2, 3, or 4, or every 4 months thereafter if that therapy continues. So, as you recall, Cures 1.0, which thankfully is going to go away pretty soon, was not so robust and had some fragility about it that made it less an optimal system. And we then jointly went to the legislature and obtained some monies and got the authorization to build Cures 2.0, which has now been launched since since January a year ago. So in our business analysis in building 2.0, we took a couple things into consideration, what we learned from 1.0, paramountly that we didn't think the information delivery was as optimal as it could be, given the state of art and the lowering costs of data analytics. We thought we could do a little bit better than a simple presentation of a patient activity report. And we also had other needs to serve researchers and healthcare officers with de-identified data sets that we were unable to produce before except manually, which was a labor-intensive effort. So we engaged SAS Fraud Framework as well as a local application builder, MCore, to help us devise a new system that provided a few more features than the 1.0 had offered. One of which was the automated registration process, which is, although not perfect, is probably a huge improvement over the old paper registration process, which took months and months and was very it was difficult for the applicant to make the application because they had to produce and notarize so many documents to send those in. So although not perfect, it is running rather smoothly now, and applicants are generally approved within 24 hours. So it's a vast improvement. Delegation authority is a prescriber or dispenser can assign an assistant individual on his staff to be able to launch the queries on behalf of that clinician. It's not entirely perfect. The clinician still has to sign in to get the response back. It doesn't go back to the delegate, and that's because I have 1,700 lawyers that told me I can't do that. So the professional has to see the data. So that's as good as we can get that, and it's an improvement. Patient safety alerts messaging, I'll get into that in a minute. Compact flagging, when prescribers have a patient, particularly under addiction treatment regimen, that they really don't want the patient to get prescriptions through any other prescriber. They often engage in a compact or an agreement. They can denote that in Cures now. We allow that him to flag that person with that compact notation, allowing other prescribers and even dispensers to see if that patient does present himself to another professional, that he does have that compact and he probably is putting himself at risk by seeking medications elsewhere. And peer-to-peer communication gives both the dispensers and the prescribers the ability to if they view what they believe to be as an at-risk patient or a patient that's been flagged as a compact individual, they can send an email within our secure Cures environment to the other prescribers for that same patient to suggest maybe we should consider this person's overall therapy or discuss it. So we get 145 megabytes of data every single day. And in order to facilitate our analytics, the first thing we have to do is deconflict or to resolve the patient entities, because as you know, there's only a name, date of birth, and address for any patient on a prescription. And even well-intended patients can be presented in a number of variations. You'll frequently see just Avenue, Street, and Boulevard, mixed up. And dates of birth of people getting to be as old as me can be inadvertently mixed up. And of course, the diminutives of names can vary quite a bit. So deconflicting these variations is a huge step, because you're adding 145 megabytes of data into a terabyte data set every single day, and you have to re-resolve that every single day. And so we do so with basically by this algorithm where the name, date of birth, and zip 5, or name and street address and city help deduplicate that individual in an automated way. While admittedly, John Doe in San Diego may in fact be the same John Doe as our Sacramento John Doe, this algorithm would eliminate that person for the sake of realizing too many false positives. So we thought it better to diminish false positives than to perhaps interject somebody who may not be John Doe. So once we've deduplicated or deconflicted these individuals, then the system parses out the contemporaneous prescriptions for all these resolved persons, and then calculates the medicinal values for that person, and thus producing the alerts when that medicinal threshold. So every morning, our alerts are refreshed. We produce about 250,000 alerts a day, and a prescriber is alerted when his patient is currently being prescribed more than 100 morphine milligram equivalents a day, or if he's been to 6 prescribers or 6 pharmacies within the last 6 months, whether he's is receiving presently more than 40 milligrams of methadone daily, or whether he's been on opioids for more than 90 consecutive days, and whether he's currently receiving both benzos and opioids. These are intended to be assistive to the prescribing clinicians, in no way dictatorial, but it's been our experience that the medical information systems remain siloed at this time, and perhaps an internist in one system may prescribe some opioids, and the next day the patient visits a psychiatrist in another system and he prescribes benzos, and that chain would never meet except for me. So we feel we're providing a safeguard here that didn't exist before, that we believe can and should be advantaged by all clinicians. And as I mentioned before, the system also produces quarterly de-identified data sets, 58 individual sets for each of the counties, and 1 statewide data set. I share those with any county public health officer who deems to sign a data share agreement with me. I also share nationally upwards with the Brandeis University, which operates the PDMP Center of Excellence on behalf of the federal government. They have a number of federal government grants to basically act as the think tank entity for all things prescription drug monitoring. So I contributed to that as well. I'm working closely with the California Healthcare Foundation and the 24 county coalitions they're sponsoring to combat opioid abuse, and I'm working very closely with their epidemiologists in all those counties and making sure they get the data. So if you have any questions, that I think does it for me. Yes.
Dan?
First of all, thanks so much. It's a great system. I'm registered, I don't know, a community pharmacist, but I've never used it. And so before the meeting and seeing that you were going to be here, we'd have the opportunity to get some information from you. I went to one of the local community pharmacists in my area, and I asked about the Cures system, how's it going? And I have a few questions. Do you mind would you like them one at a time, or?
Yeah.
So in talking to one of the pharmacists in my area, he mentioned that there seems to be now it could be on 1.0 and not 2.0, a 7 to 10 day lag period from a prescription being filled at another.
Well, there can be, there very much can be, because the statute, frankly, I think is old, and that's something maybe we ought to look at in discussing legislation, because the requirement is you don't have to even submit your dispensation report for up to 7 days. You have 7 days to report it. So if you do that, there's going to be that lag. If you send in our system, and we have a contract with Atlantic Associates as our front-end collection vendor to do the initial scrub on data, but they turn that around and send it. They're capable of accepting data on a real-time basis, and they can turn that around. We get it the next morning.
And then he mentioned that the day's supply, that it doesn't indicate a day's supply, and so if it's 60 tablets.
Well, we have it, but it's not, for real estate purposes, it's not on the report itself. Yeah, it's very important for our calculations for the medicinal values, but, there's only so much space on the.
Yeah, well, his concern, of course, is the abuse issue. 100 whatever, and if they're taking as many as 6 a day.
Yeah.
Or prescribed 6 a day.
If I'm not mistaken, if you download it to Excel, I believe it provides the day's supply, but that may be my Alzheimer's working, so I have to look into that.
And evidently, from time to time, they just get NDC numbers rather than specific pharmaceuticals.
That's when, and if they check those NDC numbers, they'll see that they don't correspond to anybody's list of NDC numbers. So in other words, until that error is corrected, we'll show the number that was provided.
How would they check an NDC number?
Huh?
If I saw an NDC number on the screen.
There's a number of resource books, Red Book is.
There's
the one that
an
comes-
internet site you can actually find.
Okay.
Sometimes, I think probably one of the things you're finding is the NDC number they just can't match because there may be an incorrect entry from a pharmacy, and that's
Yeah.
probably what.
And
why
when
they
that's the
haven't-
case, we thought it'd be at least some value, at least provide the number that was provided in case it makes any sense to anybody seeing it, yeah.
So as a regulatory body, somebody doesn't have the day's supply readily. How do we take that into consideration when we're looking at pharmacy either abusing privilege of dispensing, addition of using writing? I mean, where does the whistleblower come in, either as a regulatory body or as a professional?
Sorry.
And I'm sorry to,
No problem.
The 250,000 alerts a day that are sent is indicative of, the criteria that Mike just went through. To me, the 250,000 alerts a day is too many for any practitioner to really manage. If you've got more than 1 or 2 of those alerts coming your way, you can't possibly manage it. So in the event you are a pharmacy and you cannot somehow decode what that 240 pills is that like a 1 month supply? Is it a 1 week supply? How do you do it? Maybe that's a little more difficult if you just have one patient. But if you have one patient on a bunch of different medications, over and above, you're going to have a concern based on the fact that they're on so many drugs. And to me, I think I've always thought to generate that many alerts, the 6 practitioners, 6 drugs, 6 pharmacies in 6 months, I think I put one too many 6 months in there. It's generating too much. You need a higher threshold. Like maybe a more meaningful one would be 12 practitioners in 6 months with 6 pharmacies or something, where it shows or diversity of pills. I don't know. we can see the day's supply when we look at our cures reports. And I don't know why we can see the day's supplies if the practitioners themselves cannot. So that's something I'll look into, I don't
go
know.
into the system and look at it. I just don't remember right now. They may get it.
But for us, that's a pretty germane thing.
Yeah.
So,
Especially as a, you know, and we talk about red flags all the time, and important that the people that we are working with, that they have a sense of whether or not there's an issue or problem or there isn't.
But
And that's
is
critical.
is the instructions on there? I remember seeing the instructions and the quantity on there.
Quantity it has. I don't believe it has
It
instructions.
doesn't say
on
like
it.
how many times a day or anything you're taking it?
no, the instructions aren't in
I've
there.
never used it, so my information is
Yeah.
secondary.
But somehow or another, it comes through on our reports, so there is a calculation that's
I
being
want to
done
say
within the
it's there. I
system.
just can't swear to it right now. I just don't. I don't go into a dispenser or prescriber role very often, so I'm not sure what I can't just remember what they see right
It's
now.
where I go all the time.
I think the bigger issue, though, for the dispensers is why aren't they getting any of these reports? The prescribers are getting them. Why aren't the dispensers getting them?
Well, I'll tell you why. Because the incoming identification of the prescriber is based on the DEA number, okay? So if a pharmacist is prescribing, they do have a DEA number, and hopefully they've entered that in their cures record. We can make that link and provide those alerts to any pharmacist who is prescribing. We can do that. We can't make any links to any pharmacists who do not have a DEA number or
But could the report not go back to the pharmacy so that the pharmacy could see it, not specific to a pharmacist, but to the pharmacy where we somehow find a way to manage that account? Because with corresponding responsibility, it's one of the things that we expect the
you know what,
pharmacy to
we
manage.
can think about that. We didn't initially because I was you worried about 250,000 alerts coming in just statewide. You imagine what one pick would see for his entire crew, in terms of alerts for a day, so we'd have to take all those things in consideration. We can make a link of a patient to a pharmacy, and we can send, if we had a communication channel to that pharmacy, an email address on file, we could, or we'd have to have a special pick account role so he can go into the system and see all the alerts for his pharmacy. It would take quite a bit of design and modification, but it could be done. If you're sure you want the pick to see however many hundreds of alerts be coming in representing all the dispensations for that whole store.
Let me bring one or two of our inspectors, and we'll work with you a little bit
Yeah,
off the side
sure.
and see what we can generate and what it's going to take to generate that within the system.
Yeah.
Because I think it would be a lot more meaningful for our dispensers to have that kind of information available.
I'd be glad to work with you guys.
Well, it'd be a lot more meaningful for us because we go in there and we sometimes accuse them not behaving properly, and they say to us, well, information I have, and it's them who are suffering consequences.
It's a little different, Stan, when you walk in and get a prescription filled. This is important, this is different. When you get a prescription filled, if the pharmacist checks cures, they can see where you've been for the last year. That's completely different versus an alert that comes in is that if this patient appears again, you might be aware of that. And so the system still works for pharmacists. I don't want to make it sound like it does not. It's a very valuable system for pharmacists.
I don't want to minimize the system either.
But we'd like to use some of the alerts that are available to the prescribers to further enhance the ability of a pharmacist to potentially identify doctor shopping.
And certainly I think the most critical workflow for the pharmacist is at the time he's deciding whether he wants to fill that for that patient, checking cures then. And you have all that information presentation. If you looked at that history, you would see the same thing as the alert would tell you, The alert's just an after the fact
Right.
sort of thing. And if your patient's already gone from your store and picked the prescription up, I don't know how that fits into your workflow.
Well, there they could flag it for the next time. I mean, there are ways the
Sure,
system,
sure.
and pharmacists can have various options, and part of the reason we're doing this presentation is to alert pharmacists in our viewing area here, I'm starting to sound like a broadcaster, within our viewing area of some of the services available to them to use. And pharmacists haven't had these presentations as a general rule, so we're trying to.
And something
put the
to
information out there.
Stan's point, I mean, I was looking, one of the reports, alerts you have is patients who have an MED over 100 per day, which is the morphine equivalent. So if I'm checking that as a pharmacist before I dispense it, if I don't have access to the day's supply, at least that would trigger me, hey, this is
Right.
a high dose, I should be careful on what this patient's getting.
Yeah.
So
Yeah,
some of
I
these,
do-
I agree that some of these alerts would be really helpful. And they should be done proactively. The value of Cures is to do it before you fill the prescription, not after.
Right.
And lastly, if I may, promethazine, which is so terribly abused now.
You're preaching to the choir. I support anybody's effort to get fives on the,
Yeah, I mean, and
The
that's what,
reporting list,
you
yeah.
know, and we hear about it all the time. I mean, promethazine on the street, $600 a pint.
let's put it this way.
All kinds of-
If
Promethazine with
anybody,
codeine.
a dispenser reports a 5 to me, I don't reject that. We'll take that in and we'll report it.
Okay.
But it's just not required to by law yet, and that's where we need to change the law.
Well, thank you for being available and for answering my questions.
Sure, you bet.
One of the questions I have, Mike, for you is, one of the questions I keep getting from providers, from prescribers, is I'm a physician. I want to know what has been actually dispensed under my DEA number.
Right.
And I was recently at a meeting at the American Society of Health System Pharmacists for other board of pharmacy across the country, and there are other PDMP programs that do have that report so that providers, because to me, it would be a really good way to detect if there's been diversion going on.
I hear what you're saying, and there's two things to that. Number one, our statute, which is so highly prescriptive, says a prescriber shall register for and to receive access to in order to obtain patient history reports, period. Doesn't say the prescriber's history report. So maybe not authorized by statute. Number two, I'm also aware of a number of states that discontinue the practice altogether, will not go back to it, because they've had prescribers who got their history and then took their books based on that. You know, they modified their documentation based on, and in fact, they've arrested, in Texas, they've even arrested a couple docs because those prescriptions were actually not theirs, and they put them into their medical histories as though they actually wrote them. So they kind of implicated themselves. So there's some enforcement reasons not to. I mean, I'll be glad to talk about it, but I'm not personally ready to move in that direction yet. I don't know that besides, if a doctor perceives someone else is writing those scripts, what can he do about it? He can go to the pharmacy, and the pharmacy says, well, no, we got those with your signature, so it's a fraud. So what do you do? The next best thing is to call the police.
Sometimes they don't know until a pharmacy calls them to validate a prescription. So
Yeah.
did you really write this? And then they're thinking, oh no, I've got some prescription pads that are out there. And from our side, what we see a lot of cases, there are diversion cases where prescription pads have been
Sure.
stolen.
Oh,
And
yes.
nobody's really detecting these because the providers don't have a way. I would argue on your first point that if the physician's name, if I'm a physician, my DEA number's on there, that isn't a violation of patient history because I should have already known about that if I wrote the prescription.
Mm-hmm.
So there's no violation of patient history there. And on the, I think there's more value on the enforcement side to give them that information than to say they're going to cook their books to be able to try to
Well,
find
right.
it.
I mean, well, they can immediately go to enforcement if they suspect anybody is
How are they going to know? Because right now, they really don't know sometimes. And there's a lot of these prescription pad companies that give you minimum supplies that you have to dispense, and they may not use them, and they may just not have them.
Sure.
So I just would, if there's,
Very
any-
way to
if we're going to be
debate.
doing any statute-type changes, I I would, I mean, that's my opinion. I'd be in favor of having a process where providers could actually check. I think they have right to that information.
And I
And it
think-
might help us notify pharmacies of diversion.
And I think more importantly even is tightening up the security prescription form itself. We need to uniquely serialize those so we could track them. Those features, the existing features, I don't believe help very much in terms of preventing diversion or even helping to investigate diversion, because it doesn't even, the statute doesn't even call for a uniform look and feel. It just provides a list of features you must have, but then you could design it any way you want beyond that. So some poor investigator, he can't tell, there's no model for him to see whether this is a good script or not, just by the look of it. There's all kinds of deficiencies in the existing requirements for the paper. I wish we go to electronic.
That's what I was just going to say. With the problems we've got with the security printers, I think we're far, because we just did a number of investigations in that area too. We may want to try to really do what New York has done and really move towards all e-prescribing for controlled substances, which solves the problem in a different way where you don't have the security risks.
Except for the emergency departments. There's a
No,
big issue
there'll still
going
be a
on with
need
it.
for some of that, but I mean,
There'll be a line for
but New
paper.
York has been able to have amazing results based on their e-prescribing. So,
And we don't need 30 security printers either.
no, DOJ
No.
could go back to issuing the
But
forms.
those prescription diversions put dispensers or pharmacists at risk because they have to do a lot of scrutiny on trying to make sure, is this a real prescription? Because some of those diverters, they look really good.
Well, they can buy
There's-
the paper online.
There's all kinds of incentive to divert because one pad can easily have $1.5 million value to a diverter.
Ann?
The compact flagging that prescribers can use, the compact flagging feature, is that available for the pharmacist to see when they pull up a park?
Yes, it appears on the par. When it appears on the portion that tells you all of the person entities that you selected to composite this one patient individual you have in front of you. In other words, John Smith, Jonathan Smith, and Johnny Smith. They'll show which one of those the doctor has compacted, and then on the next page it gives that doctor's information for you and the peer-to-peer messaging capability for you to contact him. Yeah.
Any other board member questions? I'd like to recommend, I mean, if we're going to be doing something with this, I think Stan make a good suggestion to include the day supply in future reports. And I really would like to see us go after the providers be able to run their reports, because I think that would protect pharmacies from, I mean, I don't know what the other board members think in terms of doing that, in terms of a recommendation. Because, I mean, just if I've got a book of checks that's assigned to me, I can go online and say, okay, here's all my checks, and Greg, you're an accountant. Don't you want to reconcile your checks out there? So the ability for a provider to have access to what's been issued to them, I think is very, really important to have that report. So if we're going to go after any type of changes, I'd like to see us propose that.
Yeah, that'd be.
Yeah, great
that'd be
idea.
really good.
I think Stan mentioned that too, yeah. Greg?
You need a motion?
Yes, please.
So moved.
Second.
Public comment. Oh, we have one.
Running
Hi,
up from the back of the
VJ.
room.
Happy New Year. Good to see you.
BJ Bartleson from the California Hospital Association, and I want to personally thank Mike and his staff for assisting the Hospital Association with a number of endeavors. One of the things I got to thinking about was how does CURES work operationally, for instance, with emergency departments and your work with the narcotic, the 24 sites? We're trying to have timely communication in emergency departments where many of the health information exchange management systems are trying to understand the CURES information quickly so that the providers don't have to get out of one system and go to another. Are you finding any easier way to make that happen?
Well, as you know, the AB 40 is out there right now, and I'm I'm certain my department is not going to oppose that. So, I personally am looking forward to getting those authorizations to do that interoperation, the federation with healthcare systems. I think it's worthy for everybody to look at and support. I believe that the workflow is enhanced if Cures can federate with the healthcare system. So a sign-on into that native system is also a sign-on into Cures. And our little icon application would just appear at the bottom of that electronic health record. They just simply open it, do their work, and close it, and you're always in Cures as long as you're always in your own system. I'm very much in favor of that. I think that'd be a tremendous workforce enhancement. And now that we have this required use statute, that I think it would facilitate that required use.
Thank you.
Thank you, BJ. Just one, Greg, if you don't mind modifying, should we also consider looking at shortening the time to dispense per the comment that Stan made about the 10-day delay? And I think, Mike, you also mentioned it, that they now have up to a week. Should we shorten that in terms of our
Yeah.
recommendation?
What was the
Make
wisdom?
it 24 hours?
What was the wisdom in deciding the lag?
Uh-huh.
Or was there? I shouldn't say was there wisdom. What was
I
it?
think it was merely a technological accommodation at the time that Cures 1.0 was built. That's probably all systems could probably
It used to
handle
be
at the
once
time.
a month, and then it went to once a week, sometime about the time we added 3s and 4s to the system.
And I wouldn't be surprised if some of the smaller shops asked for that time, just for their own technological limitations as well.
What do you think, Ginny and Mike, that we should change it to instead of 1 week?
I think within 24 hours, frankly, is, I think, quite adequate. I don't think it has to be real time. And I think 24 hours provides for very affordable compliance as opposed to real time. So
Let's see what that brings in just with the immediate reaction to the people in the room.
Are you okay to modify your
That
motion?
is a friendly amendment to my motion.
Thank you. And Stan, you
On a
okay?
second.
All right, any public comment regarding that additional?
Wow.
Yes.
Oh, here we go.
Good morning, John.
We just wanted you up in the front of the room. What the heck?
Good morning. Happy New Year.
Happy New Year.
John Roth, CEO for California Pharmacists Association. Regarding the last idea brought up in terms of 24-hour reporting, I think there are some very practical concerns, as Mr. Spall mentioned, in terms of a pharmacy's ability, either through a workflow standpoint or through a technological standpoint, to meet such a strict threshold. So we'd like some more discussion on, maybe it's not 1 week, but 24 hours seems very stringent, and a pharmacy's ability to comply with that could be challenged.
What do you recommend?
I think certainly the 1 week is currently adequate, but I think if you were to look at maybe something like 72 hours, give them, in terms of batching workflow, at least a few days to accomplish that, that would probably be a reasonable medium.
What if we keep it at 24 hours, take it to the board?
Why don't
and
we go
then-
to 48?
You want to go to 48? Is that okay? And then we can have open discussion at the board meeting, and maybe there'll be more stakeholders that can actually provide, because this is just a committee recommendation at this point.
Thank you.
Thank you, John. All right, any other public comment? Okay, and I just wanted to, Valerie, do you want to, for roll call, you want to introduce yourself so that we have you on the record?
Yes, Valerie Munoz, public member.
Thank you. All right, I'll call for the vote. All in favor? Yes. Okay, thank you. Thank you, Mike.
Wow, Mike.
All right, next on the agenda, Jan. Is you here? You're here in,
She's via telephone, but
oh, okay, great. Want to come up, and we're going to do the UCSD presentation. Set up. So just some background, at the April 2015 board meeting, the board approved an 18-month pilot study under UCSD School of Pharmacy involving use of an automated drug dispense system for prescription medication, for which staff at Sharp Hospital in San Diego and their families, this is employees that are utilizing it, could pick up their outpatient medication, and consultation would be provided via telephone for every medication that is required as per law for a first-time fill. Since that time, our committees receive quarterly updates on the study, including how the system's been used. As authorized by the board, UCSD will collect data through the first quarter of 2017 and report the findings at the May 2017 board meeting. At the most recent discussion in August, our committee sought information on patient consultation. The committee was advised that the patients receive a text to alert them that their medication is available. New prescriptions are placed on hold by the system until a telephone consultation takes place. During this meeting, we'll hear an update from Dr. Hirsch. Attachment 2 includes her PowerPoint presentation as well. Good morning.
Morning. So I'm Kim Allen, and I'm here with Dr. Hirsch is calling in. She'll be giving the presentation, and I'm here. I'm the manager for the Sharp-Reed-Steele pharmacies that support the kiosk, and I'm here to answer any operation questions that you might have.
Thank you.
I believe we have Dr. Hirsch on.
Dr. Hirsch, are you on the phone?
I am on the line.
Softly on the phone.
Maybe we can move the microphone down. Does that help? Yeah? Well, that's.
Can you hear me?
Yeah, we can hear you
Yeah.
now. Can you hear us?
Okay. I can hear you, yes. And are my slides up?
Yes, and Kim's here, so we'll go up with your
Okay.
slides.
Okay. So I'll give a brief update, and then as Kim said, so she's here for questions, and Sarah Lake, also from Asteris, is on the phone for if there are questions from the more script center operation perspective. So if you want to move my slide to slide 2. Right, I'll just give an update of the script center kiosk, and then a little bit on the study and where we are on the timeline. Next slide. So you should be looking at pictures, and to your left, that is where the Screp Center is located in Sharp Memorial Hospital. It's in sort of a coffee area in the first floor lobby, and if you look to the back of that picture on your left, you'll see it in the background. And then to your right, if you're looking in the door, that is the Script Center there. So that's its location. Next slide, please. It should be enrollment. And you'll see a graph of the enrollment from the go-live date back in January 2016 until through the end of November. So all the data I'm presenting are through the end of November. There are 338 users through that time period, which represents about 7% of the campus employees. And we have those broken down for you there in day and PM shift.
I have a question.
If you estimate about 2 people per household, that's about 9,600 patients, possible patients or people that are represented by those 338 users.
Dan, I think we have a question.
So regarding the usage that you're experiencing, out of 4,820 employees, would you consider that number one that indicates that the employees have embraced this kiosk system?
So I will answer that, Jan, if that's okay.
Yes.
I think that there are, Sharp is not a closed system. So we have lots of challenges as to where employees get their prescriptions. They have the ability to go to any pharmacy in the system or within the community. We have multiple health plans that we service. Not all of our employees are specifically Sharp Health Plan employees, which is our primary insurance. We have Kaiser employees. So it's not as high as we would like. I don't think that, I would like to say that if you recall, this wasn't our original choice to have the kiosk. We preferred to have it at our corporate offices where we think and thought we would have a higher usage because of just the population. So yes, there are some concerns. And I think that what I would like to emphasize is the employees that are using it really like it. And Jan will go over that in more detail.
Well, my curiosity is, are you trying to fit a square peg in a round hole? I mean, is it a convenience issue, or is it an issue to make it a closed system where everything is a Sharps entity rather than it's a convenience to your employees because the community pharmacist may be closed, or it saves drive time? I mean, the original presentation that you brought to us regarding why this was going to be a good program for so many of your employees.
Employees, are they all aware that they have this opportunity available?
So with the volume, it's definitely a challenge to inform the employees of the kiosk. We have lots of barriers for whatever reason. I think that for the employees that are choosing to use it, they find it very convenient for them. And like I had mentioned just earlier, it wasn't our first choice. We were asked to do this because it's in a licensed facility. So our goal for this study is to expand the use of automated delivery. I think that as we move forward, I think Sharp will have to see if this is, volume that we want. It could be that this is exactly what we're looking for those patients that are using it. It's hard to tell right now. As we, part of the other plan is hopefully if we prove that the study is effective and that we don't cause harm, our goal is to put new prescriptions in there and allow it for patients, for discharge patients. That's one of our other.
What methods have you used in order to notify people that it's available?
We go out, we round with the different nursing units. We have a table at in our cafeteria.
So you don't publish it in any kind of a newsletter or anything like that?
We are mostly electronic, so it's on the electronic
Okay.
newsletter, yes. And we've presented at all of the major meetings of executives and down to the engineering level. So yeah, we've tried to get it out there.
So we could conclude that most of the population is aware of it?
No, I wouldn't conclude that at all.
Okay.
Like I said, it's a large campus. Employees are in and out. They work we have 5 hospitals, so they'll go between different hospitals. That might be their home base, but it's not necessarily where they staff every day.
And during our last presentation, one of the things we noted was there was a large percentage that was over the counter. Is that still continuing to be an issue?
The future slide.
It's on our slides.
Oh, it is, okay.
Yeah.
Right, because then I think, to Stan's point, I think if it becomes a dispensing machine for OTCs, that actually would be convenient, but it wasn't really the intended purpose initially.
I think, can we let Jan?
Yeah, go ahead.
Continue?
One quick thing, did you have an overall population count that you figured, like how many of was it 9,000 patient population ultimately? How many of those people would have prescription medication in all likelihood? Is there any way you made an estimate of how many of the total population? Because I think that's a little bit what Mr. Weiser was trying to get to.
I don't have the numbers in front of me, but yeah.
Okay,
we
but
did.
there was a general population that of your 9,000 employees, maybe 60% of them have prescriptions, and of that, a certain percentage would go this way.
It's all an estimate based on, volume, insurance data of how many prescriptions a family would have. So we did those estimates.
Okay, so you used overall population stats and applied
Yes.
them to your population.
Because we're
Okay,
not a
that
closed
makes
system,
sense.
so we
Yeah.
have multiple.
Thank you. Poor Jan.
Next slide.
Okay. Okay, if you want to go to my next slide, please. You should be looking at a graph, and it says in the top right-hand corner, pickups by type in a yellow box. And I think this gets to one of the questions here. This is by month, and each one of the bars is broken down into OTCs, which is the top teal color, refill prescriptions, which is in the middle, the light blue, and the new prescriptions, which are at the bottom of each column in the dark blue. And it's overall by month, it's about a third, a third, a third. So we're averaging about 88 prescriptions per month. And the really great news is the second bullet point on the right is that we did surpass the number needed for our study on December 7th, and that was 820 pickups. So our data collection is complete and ended at the end of December. The data we're showing are through the end of November. We haven't looked at December yet. Looking at the next slide, it should say on the top right-hand, pickups by time. This is during the weekdays. And you'll see on the x-axis the hours that the pharmacy is closed, early morning and the evening. And you can see the majority of prescriptions are being picked up and OTCs are being picked up in the hours pharmacy is open, but there is activity, on the hours that are closed during the weekday. And then the next slide, it shows pickup times by the weekend. So the pharmacy is closed, the regular pharmacy is closed during the whole weekend. And you can see there's various times of day, but what you do notice on here is more OTC products being picked up on the weekends. And that's the teal in each one of those bars. And the next slide just sums that up overall. And so this is looking at the total number of prescriptions that have been picked up, or total pickups, 1,481, and about 28% of those were after hours. Of the new prescriptions, 502 pickups, about 22% of those were after hours. Of the refill prescriptions, slightly less, 19% were after hours. And the OTC pickups is where you do see the difference, with a larger percentage, 40% of those being after pharmacy hours. Now go to the next slide. We've added a tracking for consultations to this update as requested by the committee last time. So these are consultations that have occurred during the study period by month, down your left. The second column is titled Total Prescriptions with a New Pharmacy Number, in which the pharmacist released the prescription for pickup at the script center. So these are all for the script center. The new prescription number is a way that Asteris, the maker of the script center, tracks prescriptions. Some of these may not necessarily be new to the pharmacy or the patient, but they have a new prescription number. The pharmacist actually releases the prescription after the required counseling is provided. So that first column of numbers is the total number of prescriptions that had a new prescription number and the pharmacist released for pickup at the script center. So that, for example, in March there were 49, and of that 49, moving to the right, the new prescriptions requiring counseling, including transferred, and the counseling was provided for 28 of those. However, there are 21 of that 49 that were prescriptions with a new prescription number. They did not require counseling because Sharp is doing a rewrite with no changes in therapy, and counseling was not required. So you can look down the first column of numbers and kind of see the steady state of number of prescriptions from the kiosk. And if you look at the number that are prescribed, that are having counseling versus not, it's about half and half, and it differs by month. So that's an update on the consultations that are occurring for the script center. The next slide is just to reiterate again that to date, no complaints have been received by Sharp. There are testimonials, and they have others also. But the first one is mainly this person works on the weekends. Now they can pick up their prescriptions when the pharmacy is closed. The kiosk is convenient. The second one is they love the script center. They don't have to wait in line, and everything has been easy for them. And this person works the night shift, so it's super convenient. And there are others that they've collected and have permission to share. Then the next slide, you should be looking at the study design, just to remind you of what we will be presenting to you next. And the study started in the middle of the slide in March in the green box, and it continued to month 6, which was August, and then we extended it to month 10, which is December. Before the study, to the left of the line in the center of the slide, there is a regular counter return to stock rates, and we'll be comparing that to the return to stock rate of the kiosk and also the regular counter during the study period. It's to the right of the line. Also at the kiosk, we are collecting a consultation log, which is asking if the patient still had questions for the pharmacist. We are also tracking the time to pick up from prescription fill in the kiosk and comparing that to the regular counter. And there's a patient satisfaction survey that's being conducted in the kiosk. And the regular counter, again, will have the return to stock rate to compare. The consultation log was also completed there for a sample of prescriptions, new prescriptions, and the dates of the weeks that was done are shown here. And the time to pick up will be compared here to the kiosk. So that's a reminder of what the study part is. And then lastly, the study timetable. We started back fourth quarter 2015 was kind of the pre-kiosk implementation. The implementation of the kiosk started this time last year in first quarter 2016. It was implemented in the second quarter through the fourth quarter, March through December that I just showed you. We're now in the first quarter of 2017 conducting data analysis, and we'll be ready to report the results to the board second quarter. The two dates that we have that we know of are April 18th, which is an enforcement committee meeting, and the May 3rd, 4th board. And then the plan is for SHARP to continue the kiosk operation until the Regulation 1713 is revised. That's the last slide. You might want to keep that up in case there are questions. And are there questions for me or Kim or Sarah?
I have a couple of questions. I'm a community pharmacist, Dr. Hirsch, and you know, to be very, very honest with you, I've always tried to be very sensitive to customer or patient consultation and how important I value it and how important I think that the patient should value it as well. I also read the paper that was in our packet that you co-authored regarding patient requests for pharmacist counseling and satisfaction. And some of the things that you say here, I mean, I'm not quite sure about your perceived perception about the value of consultation with regards to a dispensing machine. I mean, in one of your conclusions, you say that no perceived barriers to pharmacist access existed. It appeared that there were none. And I just, you know, I'm not sure about how a patient would feel, you know, trying to initiate a consultation when standing in front of a vending machine, if you will. And I'm not quite sure. I realize that when you do new prescriptions, you don't allow the prescription to drop in the vending machine without a consultation. But I don't. Intimidating isn't probably the word I'm looking for. Just reluctance of a human being to strike up a conversation with dispensing machine and a TV screen. And so I'm concerned about that, not just with your dispensing machine, but with any of them. And additionally, in one of your conclusions, you say that there are no perceived barriers to pharmacist access appear to exist. Patients simply did not perceive the need to ask pharmacists questions about their refill. I'm not 100% sure that that is an accurate conclusion. And then you go on to say that the effect of the machine technology on pharmacist-patient interaction and data collection in the context of prescription-specific consulting versus the broader, and I underscore the word broader, more multifaceted role of pharmacists providing medication therapy management services would also be useful to explore. And so you're you know, to me implying that they're going to collect all this information, but in my mind, there's a barrier between the human interaction and the pharmacist with all this new information being able to use it during a consultation with the patient. But anyway, that's my view of some of your conclusions, if you'd like to address them.
Go ahead, Jan.
I'll just respond to my previous study and the discussion that you're referring to, my remarks were based on the data that were collected in that study and the 3 questions that the patients were asked. It was their responses that guided my discussion. No one really thought, most people thought they did not wait a long time to pick up their prescription. They viewed the pickup process to be convenient, and the majority agreed or strongly agreed they were able to talk to the pharmacist if they had wanted to. So based on those results, it appeared that there were no perceived barriers. I agree 100% that the value of the consultations the pharmacist can offer and do offer is tremendous. But based on the results of that study, the patients in that study, that's the way they answered it.
Well, according to your study, the patient, not only the patients using the kiosk, but the ones going to the regular counter didn't ask for, consultation either when it was not a new prescription. So it doesn't look like the kiosk results are inconsistent with that of the regular counter.
That is true, and I would caution everyone to, if you've not read the study, in that study, it was in 2007, and it was only for refill prescriptions, and that was the only refill prescriptions were being delivered in that study.
Thank you.
I think the sample size, though, was pretty small. It was like, what, 116 respondents? Too. So we have to be careful with the conclusions that are drawn from a small sample size.
Right, yeah, and I understand that, but we have nothing else to, if data,
Right.
if we're drawing all of our conclusions, Dr. Hirsch as well as us, from the data that's being presented, this is all that we have to draw our conclusions.
Correct.
Can I just make one comment on the OTC? So I know that the OTC volume seems to be high, but you have to understand one of our ways to market the kiosk and to get people to the kiosk to really, because when you try to have a conversation with somebody away from the kiosk or put something on print, it's not clear as to what it is. So getting people to the kiosk to, we incentivize them just to go to the kiosk, check it out, get an OTC product to help them see what it was so that they could, touch and feel it and use it and that way and understand it.
I could see there would be a lot of convenience if you're working too and you need some Tylenol or.
Well, and if you look at the time, so 2 o'clock, that's our shift change. So you can see that a lot of individuals not wanting to, now they're able to pick their prescription up and go home. They don't have to make an extra stop somewhere. It's right there on the way out the door.
Probably also have more employees working during the day shifts. So that's probably why the numbers are greater compared as an overall whole than you do on the night shift.
And I will say that I am a strong advocate for consultation, and we consult everyone. This group has been interesting. They're primarily healthcare providers. Their counsels were short. They were not, if you're at the front counter, whether they're at the counter or on the phone, this I thought was an option because they were able to call at their convenience. So it wasn't during their break of 10 minutes. They could call in the morning before they went to work. It just gave them a little bit more opportunity to have a conversation with a pharmacist where they might not always have that opportunity.
I could just take the time from the committee for one moment or 5 moments. And so when I was hiring pharmacists in the days long gone by, and I was impressing upon pharmacists what I felt the importance of consultation is. And so I would refer to 2 groups of patients that if I felt that the pharmacist that I'm hiring could satisfy their needs with information, then that was the pharmacist for me. Group number 1, and many of the pharmacies that I had the pleasure of being part of were in medical buildings and often next to pediatric groups, which is a great place to put a pharmacy. And so what I would always refer to, and there may even be some of the audience, the young mother somewhere in her early 20s with her first baby leaving the pediatrician frantic. The baby was examined, the infant how does a pediatrician even do that with a screaming baby? And by the time the baby and the parent got to the pharmacy, the mother was in another area code as far as being frantic. And so my concern was that my pharmacist would be able to speak to that patient, the mother, and explain the situation and have her leave the pharmacy with a good idea about what the baby's taking, all the stuff that we as pharmacists do. The second group is the elderly couple, one of which I'm quickly approaching, by the way, coming in from their internist.
You already passed it.
Thank you very much. That's okay.
Right,
And,
because you're much older than me, so.
And maybe there's a hearing loss or a sight loss, or they are totally dependent upon each other in receiving information. And can my pharmacist explain to them, after leaving the internist, the situation with regards to their medications? I'm having trouble finding a comfort level with not just your dispensing machine, but with the concept of dispensing machines and those two groups that I felt it was my responsibility to protect.
Absolutely, and that's why community pharmacists will always have a role. Mail order, I mean, that's what community pharmacists are competing with. That's our way to identify and to work with our patients. However, we have another whole generation of want things fast, and being able to accommodate that by still giving them, because part of our study is to show that the consultation at the kiosk, which is over the phone, was still an effective means and to get value. And I think that you have to be able to add that third, that person that they have another means to communicate. I agree with you, and having that third person that you can have that conversation over a phone and still make sure that your pharmacist is conveying the amount of information it's critical.
Yes, Anne?
On the slide that talks about the total number of pickups, I'm just curious if you know, so there was 1,481 total pickups. Do you know what percentage that was of the total prescriptions that were dispensed by the pharmacy during that same period?
Not off the top of my head. Bill, that's probably about 1,000 prescriptions. That it would include those as well.
Those
That
are
is-
included.
yes.
So about
I'm
a
just
week's
giving you-
worth over a 6-month period, maybe.
And those are total pickups. So that's not total prescriptions.
Right.
Any other board member comments? Any public comment? Thank you very much. Thanks for coming, and thanks, Jan, for dialing in, giving us a presentation. We look forward to the final report. Thanks, Kim.
Great, thank you. Thanks all.
Thanks. All right, moving on to item C, disposal of sharps in pharmacy-operated drug take-back programs. Today, we'll have a discussion and consideration of statutory and regulatory framework and possible changes. As the board's been working on the rulemaking file to implement the board's regulations for regulatory requirements that were submitted to the rulemaking file has been submitted to DCA in December 2016 on the pharmaceutical drug take-back. And the goal is to have the regulation in effect sometime late in the first quarter of 2017 finalized. We have heard feedback from a variety of public stakeholders about the issue of the return of sharps by the public. The committee will resume today discussions about how to address the return of sharps. And the questions that were come up is what if there's an EpiPen or there's a drug component with a sharp along with it, or a needle and syringe. The concern that the boards entertain is the access of having these needle syringes mixed in with drugs in a take-back container in terms of the impact to safety of the environment and the pharmacies and the consumers that are in that area. And the board's pending take-back regulations require that signage for the collection receptacles contain the following prohibition. Medical sharps and needles, for example, insulin syringes, shall not be deposited. This is consistent with pharmacy law. In order to proceed with our rulemaking, the board decided to consider the issue of sharps, which includes items such as needles, syringes, lancets, and EpiPens as a separate piece. And when disposing of sharps, have been directed that sharps be handled separately and apart from unwanted pharmaceuticals. Towards the end of the board efforts to develop the take-back regulations, there were requests that we also accept sharps inside the pharmaceutical take-back bin. So I'm going to open up the committee for discussion. And Ginny, do you have any information about what other state efforts are going on in regards to this?
Well, generally the issue is that sharps are handled separately from pharmaceutical waste and take-back. And for a number of reasons, which also includes the Department of Transportation's transport requirements, which are over and above everything else in terms of how this stuff moves. So I see a number of faces out in the audience that are more knowledgeable about the take-back of medications than really I am, and especially in the area of disposal of sharps, although we're getting an image. It's okay. I have with me some pictures that were forwarded to me from Colorado about landfills and what sharps look like when they're in autoclaved and then they're thrown into the landfills. And so I'll pass these around to the board, but it looks definitely like you can identify what it was once, and if you were to be going through a landfill, you would come across this. It would give me pause about going there, but again, I don't normally hang out in landfills.
I think
It's just me, I know, but
one of
whatever.
the factors though that we have to consider is that once you get needles and syringes, it becomes biohazardous waste. It's no longer just drug waste. You're now introducing a potential infection component in there as well. So I think we probably need to listen to the public and get some input from them.
Well,
Greg, did you want to?
Yeah, I have a question. It seems to me that right now our requirements are that any container, first of all, has to be impenetrable. And second of all, cannot be opened after it's sealed and taken out. So nobody really would have an opportunity to, get stuck by it,
Well,
Well,
the
they
impenetrable, I don't think the impenetrable, because I think it's a liner, isn't it?
It's a liner that unless it's in a rigid container,
Right.
and it does not have to be in a rigid container in the collection receptacle. But if it is, then there's less likelihood of a stick. But if you're taking that trash bag out, it's very much like emptying your trash at home, where you're lifting it out, it resettles as soon as you lift
Then you put it into a rigid container.
And then you put
after
it for
that.
transport, right. That's to comply with that. Now, what it pretty much looks like, we've had requirements on the books in California for a long time with respect to needle exchange programs, which is where some of this arises from, at least in our law, that requires if you run a program, you have to take back sharps separately. And you have to have a means of collection, and you have to educate the public about that. In Sacramento County, I know that there's a mandatory requirement that pharmacies take back sharps. If it's dispensed with a sharp, they have to provide a means by which they can take back the
So
sharp.
it is possible to have a rigid container inside the
It is.
container. So if we required a rigid container, that would solve the problem, wouldn't it?
That may solve part of the problem, but again, just putting that rigid container on a DOT transportation element and getting it somewhere may be running afoul of the Department of Transportation's requirements for how sharps have to be moved. And so that's something that we can learn from the people in the room, because we do have some agencies in the room that are highly knowledgeable in this area. We've also got additional, I'm waiting to hear back from the Drug Enforcement Administration. I sent them certain questions last week, but with vacations, it's difficult to get responses. So I think right now, my recommendation, based on where we're going, is that for the time being, we continue to discuss solutions for Sharps, but we continue where we are, that it's kept separate. And that's commensurate with our law. So let's hear what might come in.
Public comments?
Hey,
Come on up. Good morning.
thanks, Kelvin. Yeah, I know.
My name is Kelvin Yamada, just like absolute temperature. I'm with the California Department of Public Health. This is Matt staffers. And I have to apologize. My supervisor, Allison Dabney, probably created a little bit of confusion in this, what you guys do in this rulemaking process here by sending you guys an email that might have mischaracterized some of the things that you guys are talking about with Sharps. Just to let you know, we know Jenny very well because our universes collide. We regulate the generation, transport, and disposal of medical waste in clinical facilities. Once it's dispensed, you folks have DA rules and things like that. So we are the local enforcement agency in 25 counties in the state of California. And we looked at your document here in your rulemaking process for Sharps, and we would agree with your ban in this particular instance for your receptacle for Sharps in there. Our law basically, and again, it's your guys' barbecue. You can do what you want with your rulemaking process, but we don't line Sharps containers. It's a very dangerous thing to do. Because when you line containers like that, which your receptacle is, you have somebody that has to handle that waste. And the potential for needle sticks in that is very high if you do that. We notice that you have pharmacists, looking at pharmacists, trying to remove these bags and take them to another rigid container. That in itself would create a very hazardous situation for folks. And we don't like to see that in clinical facilities. I mean, we don't. We require rigid containers. Like Jenny said, DOT requires rigid containers for waste handling. You'll see these things. She showed you photos of the landfills. At landfills, when the stuff is autoclaved, they run over them with heavy equipment. They do all kinds of things. So just because they're in a rigid container doesn't guarantee that the Sharp stays in where it's at. And so we put these protections down the road here to keep everybody pretty much protected from needle sticks all the way down. And even so, that still happens. Now, I think some of the confusion, and I have to apologize again, is Allison talked about EpiPens that are sealed and not open. But again, I think she forgot, we have a prohibition in our law that bans you from lining Sharps containers, specifically for the waste handling characteristics of it. So an EpiPen, the way you deliver it, is still a Sharp, even though it might be encapsulated. We would not like to see those go into your receptacles there because, again, you have pharmacists that are not trained to handle this kind of waste. You know, we regulate waste haulers. They have a certain amount of training to deal with those things, and we don't know what's really going to show up at your receptacles there. I mean, it could be something that, you know, we consider kind of EpiPens as like the cap on a syringe. I mean, it is encapsulated, but we don't know what the potential is for.
But if we did require rigid containers, it sounds like it would satisfy the current requirements for the transportation as well.
Yes, we have a provision that came into law about 3 or 4 years ago that allowed the combination of pharmaceuticals and Sharps in a single container. But then there were real specific requirements for that. And one of them is it had to go into a Sharps container. And our other specific requirement on there is not to line that container.
Right.
Yeah, so that's why there's actually 3 parts of our law that say that. We will probably try to get that to you folks to take a look at of how we handle that in our universe. So Allison, I think, created some of this because she said, yeah, you can combine them. She would like to see them. I don't think she was considering this particular receptacle that the waste handling or your pharmacist would have to actually pull out, take to another rigid container, and then package that for shipping.
So I know for drugs, because the DA regulations, they have to be collected in a pharmacy, but Sharps waste can be collected anywhere. There's no requirement that that be done only in pharmacies.
No. Clinical facilities, yeah, they're doing it. And us too, so the other requirement for a combination of Sharps and pharmaceuticals was that it would be incinerated, right? Because steam autoclave, what we do for other syringes, is not going to cut it for pharmaceuticals. So I think the other thing she was thinking about was you are going to take this incineration, but the fact that you have pharmacists handling this stuff in a bag, it just doesn't mix for us. So if you put sharps in a sharp container,
What are options right now for patients that do need to dispose of sharps?
from the hospital or home? From home?
No, from home. Like if you have sharps, if you have an EpiPen and you want to dispose of it, what options do they have?
You have to go to a household hazardous waste collection, probably, and you have some waste practitioners there that, or waste handlers there that would have to handle it for you. If they did know about our law, which most of them do, the sharps that have medication still left over in them would have to go to incineration. The other ones,
But Kelvin, they have to put the sharps in at home. They can't be walking around with the sharps open and exposed. They're supposed to be put in a sharps container for the disposal, which would be the same that if they were to put them in the collection bin, although that conflicts with the fact that there's a liner in there. So the sharps, the sharps that have to be in the sharps container for disposal is already in conflict with our requirement and the DEA's requirement that these household pharmaceuticals are in a liner. So you've got a problem there, and then we've got the overlay with the transportation, which is why it looks like we're going to have to keep the sharps separate.
Can't the liner be a rigid container?
That would be inconsistent with the DEA regs, which require a liner. And the rigid container is a requirement of DOT. I mean, so there's like agencies, I mean, this whole thing is like one of those evolving things that we've got all these laws out there intended to address this. And we're now trying to handle something else to put in there, and they're at conflict with each other.
yeah,
And
and I'll say unfortunately, us at the state level, we've been trying to work out these conflicts for years now, and without kind of minimal guidance
So
from
it
the feds.
continues to be easier to address them separately.
Well, it seems to be our best advice for the time being is where we left it at the time we moved the reg.
Well, we don't want to slow the pharmaceutical take-back either, because we've got that
That's already
reg.
moving.
It's already going, and we don't want to do anything to stall that. And I mean, in my perspective, it would be better to have sharps more access. I mean, pharmacies is limited. I mean, I've seen them at airports, in the bathrooms, and other places where people would use them. You'd probably get a lot more, more public protection to have it all over, rather than just limit it to pharmacies.
Yes, and we as the department made the decision not to actually make airports generators of medical waste, right? We just say, well, when you collect them, then it becomes medical waste. Really for that purpose, to make it easier for consumers to actually bring that waste stream over there. We want to overregulate that and discourage people from bringing those things back to the proper place.
Any other board member comments? Any motion that we want out of, do we need a motion?
No, I don't think at this point, other than maybe we might want to talk about we're joining with the other community organizations that are out there and with other state agencies to help educate the public and maybe even the pharmacists that when you have patients with sharps, they have certain things they have to do in order to appropriately dispose of them, and do it as a public education campaign.
And we could be part of that, I mean, the education, because they are drugs.
Well, and they're already out there doing some of these activities. It's like we're the latecomer in this game, but it helps us further our ability to do successful drug take-back, because there is a real problem with what to do with these things, and there's limited options. And we know that if they're inserted into the container, there's a potential problem. So as long as they're kept separate and we help expand maybe knowledge about where you can dispose of them and how to appropriately dispose them, maybe that'll get us to the same point. Well, we meanwhile look for an overall more global solution to how we're going to deal with this stuff down the road.
Laura, did you have a comment?
Yeah, I just wanted to clarify, because I think one of the two things that I heard you speak about, I think are relevant, which is, one is that traditionally a sharps container is only containing the sharp itself and not the drug. And so that's where we're struggling, is you've got a combination of the two, right? So there's the conflict. And even though your regulations do address, I think, the ability to have a separate container, it's basically a super container that meets all of the requirements of both the sharps container and then also the medical waste problem. And I think what we may be looking at down the road when we figure out the right solution is probably a statutory fix, because
But it's a little more complex
There's,
than
because
just
you've
a
got
straight,
the
because
federal.
you've got federal
overlap as
overlay,
well.
you've got transportation across state lines, you've got a whole series of things that make it more complex. And you've got people that have been doing things traditionally a particular way, which is also sometimes less than flexible in moving forward with a different kind of solution. But we're clearly in a position where we have some problems here.
Right. But the pharmacy law does address and require for, under certain circumstances, and I think Jenny touched on that, where there's a pharmacy that offers that provides needles and syringes. They're also required to offer, have a Sharps container, and also one of the options there is a mail-back Sharps container. So, and that's in, I think, in 4145.5 of the pharmacy law. So, but there's the piece that's missing there is the medical, the drug that's within that.
How do you have mail-back Sharps when there's a requirement that it be a rigid container that Sharps get disposed of in?
There's specific Sharps mailbacks.
They
They are
issue them,
rigid containers?
they issue them as a rigid container, so the patient uses it to dispose of their Sharps, and then they have a mail back on there when they're done.
Yeah, I had the same question.
We actually give them out to some of our patients for
Yeah,
mail
the
back.
Postal Service, they approve those.
Yeah, they wouldn't want them in those flexible bags, but that they can do drug take back in for the mailbacks, because again, there would be an immediate injury there, or likely immediate injury.
Thank you. Do we have another, did you have anything else, Calvin? No? Okay.
Thank you,
Thank you
Calvin.
very much for coming. Another public comment? Good morning.
Good morning. This is Teresa with Californians Against Waste. We're an environmental nonprofit group, and we agree that medical sharps do not belong in a drug take-back bin. We want to thank you for your willingness to do a deeper dive on the issue of medical sharps. Right now, there are successful local programs such as County of Santa Cruz, but we need a statewide policy, and consumers without convenient disposal options tend to either throw it in the trash, the recycling bin, or flush it down the drain, which poses a problem for the waste workers at the landfill, the recycling lines. You might have seen the most recent LA Times article where hypothermic needles have washed up on Newport Beach. And so we strongly encourage you to consider a separate Sharps policy, statewide policy program. Thank you so much.
Thank you.
Thank you.
Any other public comment? Good morning.
Good morning. I'm Doug Cobold, County of Sacramento. I'm a program manager, and we do a lot of the things you're talking about today. We run a landfill, we run a transfer station, we collect a lot of recyclable materials, and we also run a household hazardous waste facility, a couple of facilities. So we encounter these sharps at every level. And so we're certainly looking for a good solution to dealing with them. I wanted to give you a little bit of information that you might be able to use as you move forward with your discussions on these regulations. One, Greg brought up the fact of a Sharps, rigid Sharps container, and I think you guys were talking more about in the collection bin. There has also been discussion about Sharps, rigid Sharp containers that the consumer takes home with them and then puts their Sharps back in when they either dispose of them properly or return them by mail. So those rigid containers are a great savings to us as a local government, because for my operation, last time I looked at it, it cost me about 40 cents a pound to get rid of Sharps that are in a rigid container, approved container. It's $8 a pound if I have to get rid of those same Sharps that come in a soda bottle,
Wow.
plastic bags, cardboard boxes. I've seen it in every kind of form you can imagine coming into our facilities. And these are the ones that we see that come into our household hazardous waste facilities. These are not the ones that are ending up in the recycling bin, that end up on the sort lines and sticking sorting staff as they're going through the material that we're required to under AB 939 to try and divert. Also, we see a lot of these at the landfill itself. They come out of the trucks. Now, whether they're autoclaved or not, most of the time, we hope they are, but we never know. And so we take a lot of special precautions. When we receive a load of material like that, we'll stick it in a special hole we've dug out of the old waste. We call it our pest hole, and we actually dump that stuff into a special hole. It costs us a lot of money to do that, but it's our way of trying to protect our staff from getting stuck by that at the facility. Now, they're not typically going to get stuck walking around the active phase area. They might. We require puncture-proof boots, but where they might get stuck is when they're cleaning out the equipment, because we have those tractors, those bulldozers and compactors going over that material, and they're pulling those sharps into the machinery itself. When our staff, either our maintenance staff or our mechanics are working on it, they can get stuck very easily by something they can't see initially. So, and we don't know whether or not that's been autoclaved or not. So there's a lot of risk. What would help is to have a requirement, now whether this is a statewide legislative solution or if it's something that this Board of Pharmacies has the ability to implement, would be a mandatory approved container requirement be supplied to for every sharps that is sold in the market. That would be a great advancement in this direction. As far as the co-collection of the materials, either in the pharmaceutical take-back bin or in a separate sharps bin, there could be solutions that would meet all the requirements you're trying to meet. Ginny was talking about all the different regulations and laws that you have to comply with. Absolutely, there's a myriad of them. And so maybe there's a solution out there that combines everything together and keeps the folks that are safe, the pharmacists safe when they're not, maybe they don't have to pull a bag out because maybe the container within the sharps, within the collection unit is actually a rigid container itself. That is also lined. Maybe you put liners in rigid plastic containers that can be closed up and then shipped off as an option if we want to do co-collection. Otherwise, I agree with Teresa, Californians Against Waste, that co-collection of those is not good because, especially, like I said, the way we see these coming into our facility, I've witnessed one, they were sticking out of a plastic bag. The sharps were literally sticking out. And so my staff has been trained very carefully on how to handle these things when they come into our facilities. So, very much.
Thank you. Any other public comment? Morning.
My name is Jordan Wells, and I'm here representing the California Product Stewardship Council. And we appreciate the board taking up this discussion as the safe disposal of sharps is critically important for Californians. We're finding needles on the beach, at parks, on the streets, and even just outside our own office here in Sacramento. We are open to a discussion about this issue, but stress that safe and separate collection of sharps in pharmacies must remain a key and viable option because pharmacies are a primary distributor of sharps and must remain a key collector to ensure consumer convenience, which is key to obtaining wide use of the collection system. We also have a recommendation that the committee have workshops where the disposal facilities and community is invited because they are operating without full information. Thank you for your time.
Thank you. Any other public comment? Okay, so do we need a motion to move forward, or we're moving forward with our regulations? So we'll just report back to the board that we've reviewed this issue, and we're recommending to continue with the current language as is. Is that?
Well, or if you want to make a recommendation.
And to address the
It's already
sharps.
moving forward. It's
Yeah,
whether
we've
or
already
not
got
you
it in the
wanna-
review process. The existing regulation, there's no modification we need right now because it doesn't allow for the sharps to be added in. So that continues, and in fact, I think we're coming close to our year sometime relatively soon, but it's in the departmental review process. Laura has signed off, and we're just at the review stage. With respect to the sharps piece, though, I think that we've got one of two things. This can either be done as part of the enforcement committee, which has been kind of the home of the drug take-back provisions, or it can be sent to the communication and public education committee, where it can be discussed further there. It's up to this committee, I think, first to decide whether or not it wants to continue the discussions in this area. And if it does, then it stays here, and then at the time that there needs to be a public policy with respect to some communication, maybe then refer it over to the communication.
I think
public.
we should keep it here and dig into it and try to come up with a solution for the sharps.
And if you need a motion that we continue on the route that we have been regarding our drug take-back programs, I certainly would make that and underscore that we certainly don't want to integrate the sharps and the take-back program that we were already involved in. I just think it wouldn't be wise to do that. I think we
probably don't need a
Separate
motion
issues.
to continue on
Continue.
with the other thing, but we
Right.
would need one to delve deeper into finding a solution for the sharps.
I think it's going to be important though to involve other stakeholders because this is not only, I mean, with the pharmaceutical drug take-back, it was only pharmacies because of the DEA regs.
Right.
With Sharps take-back, it is not restricted to pharmacies. So I think by keeping it there, we're limiting access rather than, it really needs to be more widespread.
Okay, so what's your recommendation?
Who would be the committee, what organization would we work?
Drag.
We've got some of the players in the room, and they voluntarily came here today, just seeing it on the agenda without any real advance notice. I think we just continue. If I'm aware of it, I know that some of the players, hopefully they can advise me if something's going on, and then we can start working. I don't think we have to do it, but I think we need to be part of it.
I know, I agree we'd be part of it, but I don't know if pharmacy needs to be the driver
No, that's what I'm
behind
trying to say.
it, because it is more of a global issue. It's not a drug issue necessarily.
Well, it's part of it, but,
Yeah,
yeah,
it's-
but where we go, but I
I
think.
mean,
that-
who else would lead it?
Well, there's a lot of groups that are working in the space right now, and they.
Looking at them right there.
Oh, okay.
Calvin,
Come on, Calvin.
I think, hearing from the gentleman who's in charge of the trash program here in Sacramento, I mean, it sounds like there's a great opportunity there.
Right.
For savings, and
Right.
looking to them to participate in the solution in more than with, suggestions would be a significant savings for them, and would
Right.
certainly be an opportunity for everybody.
I mean, we can partner with Calvin's group and come up with some solutions.
Yeah, I think Cal Recycle has actually taken on a lot of responsibility with this. I
They
don't know
leave,
if
they
they're-
were in the room.
Is Cal Recycle here?
No.
Oh, there we go, okay. We do have,
Yes.
come on up, you're not
Yes.
gonna, no? I'll talk to you offline.
And so, and we've worked with them on these past issues there, because I know Sharps is, and again, the fact you can combine them in a container wound up in our statute. That was something that was, it struck a chord with us, because now you're putting these two things into one containment. But Cal Recycle for the landfill, and you heard the person from Sac County,
Right.
that's where they most of them wind up.
So if we don't do something here, it's not going to just drag for years. Somebody's going to make it happen.
Well,
Is
I
that
think it's
it?
been dragging for years already.
So,
I mean, more years.
Yeah.
so might we suggest to staff to work with Calvin and Cal Recycle?
Yes.
And then bring something to us that at least it would be a blueprint for us to take and go forward with?
It's a good idea.
Good. So we need a
So you want to
motion.
make that motion, Stan?
I'll make that as a motion.
I'll second it.
Second. Any
Thank
other
you,
board
Calvin.
member comments? Public comments? Okay, all in favor? Okay, we'll recommend that to the board. All right, we're going on to item 4, but I'll just do a 10-minute recess, a bio break, and we'll be back at 10:55. Seeking to use automated drug delivery systems in California. Some of the ADDSs offer new features that are not addressed in pharmacy law. During this portion of the meeting, the committee will be able to hear from interested parties about ADDS with new features, discuss current laws, and identify possible options for future implementation. How many companies are here to discuss this item? I just want to get an idea of how many individuals we've got. 1, 2, 3, 4, 5, 6. Okay, I thought there was one, I didn't know about the others. So we're going to have to limit these presentations to 5 minutes or less to stay on track on the agenda. So do we have a list going of who the, Debbie, do you know? Okay, if we can start a list so we know.
Started in the back so that we can,
Got 6 of them.
yeah, I saw. That way we'll just do them in the order they sign in.
Right, and we'll just do 5 minutes or less, please, with your presentation. So for reference to the committee, there's multiple laws that govern automated dispensing delivery systems, and it's provided in attachment 4. So the first one I think we have is A-Scribe. Is that the one who's, I think, are you here? Yeah, come on up. Ann got our timer going? Good morning.
We appreciate the opportunity. I'm Roger Morris, and this is Dr. Reef Gilliam, to talk about this. We had a quick video, but frankly, in the interest of time, we're not going to show you that. We will give you the site to it later if you want to do that. I wanted to have Dr. Gilliam spend a couple of minutes telling you about the system, and then I wanted to talk about the law, and I'm going to pass out the law as he's starting to talk to you about the system.
Thank you.
Okay. Good morning. So the technology that we use is chip technology. And so in the process of doing that, we have a dispensing machine sitting at the facility that holds 240 of these canisters. These canisters have a microchip on the bottom, and they're filled at the pharmacy by a pharmacist, and a tamper-evident tape goes on them. And we operate in multiple states, and in all the other states we operate in, these canisters go into the same tote that the liquids, creams, pastes that go out to long-term care. The nurse would then receive this canister at the facility, scan it in, and because of the chip technology, there's no way that she or the person receiving can get it wrong. So you simply take this out of the tote, scan it, and drop it into any of the 240 slots. And that then connects all of software. Now what happens is there's an electronic eye that sits right below this canister, and the canister is drug specific, so everybody on Namenda would come out of this canister. And because of the chip technology and the active inventory, we decrement whatever was put into this canister so we know at all times what's going on. And the difference between this system and the blister card system out there is the federal government measured this one, and that because of the sheer number of cards and the human handling, there's 8% med errors every day using a blister card system. In our system, we're doing about 1 million doses a month, and we run at 99.9% accuracy. And accuracy to us is not only a successful e-prescribing fill file that goes to the machine, right person, everything. The packets are specific to the individual, but it's also that the right drugs are in the packet comes out on time. And so everything is wrapped around that 99.9. And so we're many, many times safer than a blister card.
Let me just jump in, just in the interest of time, and I want to be respectful of it. To do the math, that's actually 800 times more safe than the current blister cards that are here. The piece that we wanted to talk about is California Health and Safety Code 1261.6, specifically subsection G, which is the stocking of the automated drug system. I have passed out exactly what is your current law, 1261.6 G and H. I've just highlighted and put some numbers on some pieces so it's easy to identify. Part G1, where I have put the 1, is the base law that says the stocking system shall be performed by a pharmacist. Part 2 is the section that says if the automated drug delivery system utilizes removable pockets, drawers, cassettes technology, then you're allowed to do it outside the facility if all of the following occur. 3 is the situation where these are restocked in a pharmacy. That's what A-Scribe does. It's done by a pharmacist or a tech under their supervision. The issue that comes up is Part 5, which is the facility and the pharmacy have to put a policy in place as to how to restock them. We understand that the board's current interpretation of Part 5 is that requires a pharmacist to stick this device in any of the 240 places rather than a tech or a nursing staff person. We don't understand why that is required. We don't think the number 5 as written actually requires that, and we think that interpretation makes sense when you read all of subpart 2, which I've identified here. In particular,
Just a quick question. So this is pharmacy inventory. So the pharmacy is issuing it to the clinic. Is it on a prescription? It's not a patient prescription. It's stock, essentially.
this is automated dispensing, so this is actually still all pharmacy equipment, pharmacy inventory
Pharmacy
under your
stock.
law. It is considered part of the pharmacy.
But we're not having a pharmacist or a pharmacy technician stocking it. We're having a nurse stock it.
Well, right now, we're trying to get an interpretation on that. Right now, a pharmacist is stocking it.
Okay.
How does it get from that container to the patient?
It is, the machine will actually take the dispensed prescription file, and it will produce packets like these. They're patient-specific. And so when we send.
Multiple drugs in there or just one?
We can do one-to-many. So it's really depends on what the current laws are. A lot of them, we do C2s by themselves.
Is there a bidirectional interface with with the system and the pharmacy?
Yes, and
So
there's cameras
so
in
if
the
something's
room.
discontinued, the pharmacy can discontinue that immediately?
Yes, and part of the safety, the reason why we're so many times safer than a blister card is we limit the amount of total drugs to the nurse. They have all these cards, and when we go into a facility, we'll take out 2,000 to 3,000 cards that they actively use every day. And by doing that, we reduce those total meds, and in fact, the OIG's office has come to my office. We're the only ones that can automatically detect drug diversion, because we can sense when they're trying to divert, and the software is made to sense that out.
Do you stock controlled substances in there?
Yes, we actually went before the head of the DEA, all states, and the head of the DEA reviewed our entire system and approved C2s.
Depending on state law.
And who inputs the patient information into what?
The pharmacist puts it into the pharmacy information system through the PV1 process. So it's
And that's
completely,
transmitted to the dispensing machine?
yes.
Does the pharmacy receive, because I know e-prescribe differs on whether they can receive discontinuation notices. So if I'm a physician, I discontinue something,
It's
how is the
immediate.
pharmacy notified?
Yes. Everything is real time. So any discontinue, if there's a drug recall, this would be turned off. Nobody could access it with a drug recall. It's instantaneous.
I'm not talking about drug recall, I'm talking about a therapy discontinuation. So the patient's drug level's too high, this medication needs to be discontinued.
It's instantly stopped, yes.
So the pharmacy is notified through e-prescribe of a discontinuation?
Yes.
Or how does that notification take place?
We are directly interfaced with the pharmacy, the facility's software. Whatever EHR they're using, we're directly interfaced with that.
And when that occurs, instead of having a full blister card like this sitting in there, at most, you're going to have, 2 days
One
supply?
pack.
One packet sitting there.
And we've been before 4 different states' Department of Health, and every case we were reviewed by the leadership of the Department of Health, and not only were we endorsed, they asked us to come in and take care of a few of their other problems, because the limiting drugs in these facilities in total quantity just makes the whole equation safer.
How do I know if that canister disappears?
We track them just like UPS, so it's on a manifest, and if it is removed or picked up or anything done, it sets off an email alert to the pharmacist, especially if it's a C2, that will email alert them. There's a camera on the machine, and all the users are processed in our system, so we know who everybody is. And anybody in the room has to have access to the room that's authorized through the pharmacy facility relationship, policy and procedures.
So to anyone who touches the machine, they have to put in a passcode. If there is a video camera there recording live and recording everything that goes on with it.
So if that doesn't show up into the machine, if I'm a pharmacy and I ship it, I'll know that got diverted.
Yes. In 10 years, we've never lost a canister.
Okay.
Conceivable that, so an order comes to a pharmacy, and a non-pharmacist inputs the order into the computer.
No, only a pharmacist can put a PV1 order through our system.
Right. This one, we think we know we're in compliance with everything that's here. It's who sticks this machine piece back in the machine.
And Mr. Morris, I can tell you, our attorneys strongly believe that based on the code, and we'll carry this discussion perhaps a little bit offline, the law doesn't allow for the nursing home staff to restock that in fact is pharmacy stock. It's in the custody of the pharmacy. So you have a wonderful technology, you have a real nice adaptation, and I don't know whether the board's wowed or not, but the law doesn't allow for the nurse or another staff person of that skilled nursing facility
And
to
that's where
restock.
I wanted to do the participation here. We think their interpretation is wrong.
They think yours is wrong as well.
And I think we've got other people that want to present. We're at that 5-minute level, so we're going to go ahead and do the others, and then we can discuss next steps from the board members as soon as we hear from the others.
Sure.
But thank you very much.
Thank you.
Thank you.
Thank you. And we will shoot you the link to the video if anybody wants to see it afterwards. so that
Perfect,
you
yeah,
can-
we'll send it around. Thank you very much.
Thank you. And do you have, how many installed sites do you have in California?
Oh, one.
One, okay. And there's a pharmacist restocking. Thank you.
Sorry? There's probably, I think we have 37 machines working right now, so there's like 4 or 5 states total.
Thank you.
And part of what we're talking about right now is the technology that's out there that continues to evolve, that continues to put some of our laws that make them a little more obsolete and restrictive. And so that's part of what the purpose is of what we're talking about here.
Thanks. Next, we have IMGRX. And if there's anyone else that would like to sign up, I've only got 2 names on here. Do you want to come see Laura or Debbie?
We'll put them over on, okay.
Yeah.
I'll put this in the back of the room so we don't.
Yeah, I've only got 2 names on there. Thank you. Good morning. Still morning, yes. Good to see you again. Yes.
Right.
At least in this time zone.
I am Kevin Rue, and this is Pat Iantorno. Our company is IMGRX. And given the limited presentation time, maybe I think I should focus on where we want to put machines and leave discussion of the actual technology to your questions or to a future presentation. Our business model, we got our start in community clinics. We operate in California, I think it's 21 on-site 340B contract pharmacies in community clinics. The background is that these clinics were finding that 31% of their patients who came in got treated, received a prescription, never went to their pharmacy to get the prescription filled. Pat came up with the idea with some clinic directors in Northern California to establish an on-site pharmacy, and we're very proud to say that only 2% of the prescriptions that we receive get restocked. So we have a very high adherence rate, and we're proud of that. But we still had the issue of these large clinics where we can staff a regular pharmacy with a pharmacist and technicians. They usually have satellite locations that won't support a staff. So Pat came up with the idea of a dispensing machine to put at these satellite locations and to be remotely operated by a pharmacist. With our machine, a pharmacist initiates every step of the stocking and dispensing process. Current law, as you know, 4119.1, allows a pharmacy to operate a machine under its license in certain kinds of health centers. But the law also says in subsection E that the board has the discretion to allow a pharmacy to operate a machine under its license in other kinds of health centers. And that's what we're asking you to do, is to exercise your discretion to allow us, and I suppose others, to put these automated dispensing machines operated by a pharmacist in other types of clinics. Specifically for us, our business model is community clinics and other federally qualified health centers dispensing 340B drugs.
Can I just ask you in the interest of time, how do the drugs transport there? How does the pharmacist have oversight? Is it a finished label container? I mean, we saw the other presentation where they had that canister. How are the drugs moved?
Do you want to say? Or
Yeah, really, the same way we do in a pharmacy. The doctor prescribes. They run the order to our pharmacy. We run it up, adjudicate it. Instead of printing our label 10 feet away and doing all that, we route the order to the machine, which is 10 miles away. It grabs it, says that's amoxicillin, labels it, holds it up for the pharmacist to see. The pharmacist approves it and then releases it to
You
the
mean
patient.
hold it up to see to a camera?
The machine does.
Yeah.
Okay, to a camera. So there's a pharmacist interacting with who on the other side, the patient?
Yeah, and then, well, I have a technician on the other side. When the patient walks up, I don't want them to be confused, especially the older people, with this. So, you mentioned pediatrics and older people, and those are the two people. Wait,
So the technician
Can
is
I go
being,
back at the
has
same age?
oversight from a pharmacist through a remote camera?
There's a camera there, this remote camera that identifies the drug, identifies the label, identifies the original physician order back at the pharmacy that came in, and he approves it and then talks to the patient. The patient can pick up and either talk and/or verbally and visually.
The robot selects the drug,
I
right?
think a more direct answer to your question, Amy, is that the camera's inside the machine. So the machine retrieves the drug, first brings it up to the camera, so the pharmacist identifies, yes, that's the right drug. When the pharmacist gives its okay on that, then the machine applies the label, and then it brings it back to that same interior camera for a pharmacist to approve. At that point, the pharmacist offers his consultation to the patient, and after the consultation, then the pharmacist hits the switch for the drug to be dispensed, to be released.
And
to
the
patient.
consultation's done through the same camera that's in the robot or another camera?
Have an outside camera, or we could even, we have a telephone on the.
But there's an outside camera in the front.
There's an outside camera, and
So it's like
we
Skype,
anticipate
like an
somebody might want to do.
interaction, like a Skype interaction between
yeah.
the pharmacist
Right.
and the patient?
And our technician, we would propose, would also, if the patient is intimidated, standing there in front of the vending machine, as you said, Skype can be on your iPad as well. So we would offer that and say, if you'd like to step over here and consult them.
The objective, really simple, is to try to bring the pharmacist into the treatment zones.
Yeah.
More relevant into the physician. I call it the triangle of care. There's the physician, there's the patient, and there's the pharmacist. And we're locked in together on this. And we think we're most relevant when the physician is trying to get the medication to the patient initially, particularly with mothers and sick kids. They don't want to wait. But you're right. How relevant can we be? That's what we want to find out. How relevant is the pharmacist? How do we have to shape the dialogues differently?
How is the machinery stocked with drugs? And is there controlled substances?
No controlled substances. The machine is stocked, it stocks itself. We put the order in the machine in a kind of a non-validated section, close it, the machine then goes down and says, oh, that's amoxicillin, that goes here, that's hydrocortisone cream, that goes there.
And at
then
the end of, and again, the drugs are shown to the pharmacist and they're recorded. And then the pharmacist validates that list.
Who delivers the drug from the pharmacy?
The drug
to
delivery company.
Or
the wholesaler
McKesson,
does?
The wholesaler does.
So there's a wholesaler going directly to the machine?
Yeah.
And the pharmacy signing off on that invoice?
Yes. Because when it stocks it, it then shows an item of what, it takes a picture of everything it stocks, and the pharmacist can see the picture of every drug that went, compare it to the invoice. Too much time.
In community clinics. No, not in Texas yet. We hope to stay.
How many installations in the state do you have?
We have one. We want to do 4. And to gather
There's
some
one
data.
currently?
Yes.
Northern, Southern California?
Northern, in Napa.
In Napa.
In Napa, okay. Great, okay.
Now, at that one that we've got on site in Napa, that is actually just outside our on-site pharmacy. We're trying to prove the system. It's operated by that pharmacist on site, but the pharmacist is, 40 feet away, not even that actually. So what we're asking is for the permission to move that machine to a satellite clinic where there is not a pharmacist on site. In essence, bringing our pharmacist from that on-site clinic into the satellite clinic as well.
Which is the proposal that you provided to us.
That's correct.
Yeah.
Right.
At one time, I had a couple of pharmacies that did deal with this type of a segment of the population. And my experience is that that segment of the population is requires more consultation than other segments of the population. So the consultation is a big deal.
It's a very big deal for us as well. And as another
You have to
example,
use other languages as well in regards to your pharmacists.
Yes.
I don't know how you're.
Since it's at Napa, does the machine give them a glass of wine with their drugs?
if there's a board regulation to that matter, we will, yeah. Or to the prescriber,
So
perhaps.
we're at our 5 minutes, so I need to move on to the next. I know you've got a proposal, but we don't have this agendized, so we're going to have to discuss it and possibly put it on an agenda for a future meeting.
Is there a way, may I ask, does this committee have the power to allow us to put our 4 existing machines in satellite clinics today? I mean, we're a startup company and
I'll turn to our attorneys and ask.
No, that's not the issue that's on the agenda right now, and even if it were, the committee doesn't have the delegated authority to that. It would either be, and this is something we would have to explore, I'm not sure whether or not the executive officer has ever been delegated that authority, or if it's a full board, but definitely not this particular.
not the committee?
Well, the way you're requesting a waiver of existing law, we can only waive a reg, in a pilot setting, like much as we just did with the Asteris machine. It's being done through a modification of an existing reg with pilot, and it's limited term. So, one thing that they didn't indicate is that we've had 2 inspectors that have gone out to see the machine.
Right.
And so, I'm aware that they've done that. Again, this is part of a larger issue of how do we embrace the technology that's coming forth with laws that restrict some of this. So,
We've heard 2 presentations. I'm sure there's a handful, a lot more out there. I'm just wondering if we should just do like a day forum on all the different automated dispensing machines and then look at the laws and really spend the time looking at it, maybe even have demos of what they look like so that the board members could become a lot more educated. Because I think it's limited with what we can do right now and see.
So would that be at a full board as opposed to?
I think the board should do it.
Invite the full board, yes.
That
To
makes
look at
sense.
for, and I think the focus needs to be on automation that's not in the pharmacy. So if it's in the pharmacy or in a hospital, like the automated dispensing cabinets, we've seen that, but this is locations outside where the pharmacy has oversight. That's that's my recommendation from this, if we can do that and just schedule and invite all the different vendors to come out and look at this and come up with what changes in law we need to do once and for all.
We need a motion to do that or not?
We need a motion for that?
Direct me to do it, and I'll do it.
Yes.
You're directed.
Thank you.
Well, I got one more question, I suppose, because we have 4 machines that we'd like to put into use, and, you know, we're a small company. We're not Walgreens with a lot of money that we can afford to let these sit aside until we get further action. So could we get a blessing to at least put the 4 in, you know, we got 1 out now, can we put the 4 out?
Well, I just heard our attorney
Yeah.
say that we
Yeah.
can't do this and we don't have delegated authority. So it would have to go before the full board and we'd need to get a lot more information. So I don't think right now we can do this.
I had to take my shot.
I think the committee is not going to be the body that authorizes that, and I think that's a separate request, and we'll have to look at that.
Well, we do have a board meeting coming up in a couple of weeks.
I'm not even, so,
Is it too
not
late?
having looked at this particular issue, I can't give advice about it, but I can tell you that because of the agenda, that it's not appropriate for the committee to make any decisions on that.
And Greg,
type
there's
of
going to be a lot of other vendors that are going to fall under the same.
Right.
So we might as well address the whole thing all at once.
Okay.
But if we do it earlier in the year rather than later, especially if there's
Yeah.
a statutory impediment, it'll give us an opportunity to get it resolved ideally in 2017.
Let's see if we can schedule the next 60 days.
60 days,
If we
60
can,
days?
within the next 60
You want a
days.
special one-day meeting
Yeah.
somewhere? Okay. Okay.
Thank you.
Thanks.
Next is CVS Health. Mark Johnson. Good morning.
Thank you. I'm Mark Johnston, a California licensed pharmacist. You might know me as the current executive committee member from NABP representing District 7, a position I was elected to when I was the executive director of the Idaho Board of Pharmacy. However, today I'm here representing CVS Health and their family of pharmacies that includes Omnicare. You've heard from the manufacturers, and we're certainly not a manufacturer of these machines, but we did want to appear today and talk about 1261.6G and the changes that happened recently. This section of law allows I put my reading glasses on, speaking of getting old. The automated drug delivery system, if it uses removable pockets, cards, drawers, similar technology, and now unit of use single-dose containers, it allows this preparation and stocking to be done outside of the pharmacy. So as you read down through G, it's separated into three different components. The first component is actually filling the drawer, the unit dose. So the task of placing the drugs into the removable pockets, cards, drawers, or unit of use single-dose containers is performed by a pharmacist, an intern pharmacist, a pharmacy technician. That's what happens in the pharmacy. The next section talks about delivery to the facility. That is, the removable pockets, cards, drawers, or unit of use single-dose containers are transported between the pharmacy and the facility. And then finally, the next portion is what happens at the pharmacy. This is really what I think is at debate. Who can stock the machine when the drugs get to the pharmacy? The facility, in conjunction with the pharmacy, has developed policies and procedures to ensure that the removable pockets, cards, drawers, or unit of use single-dose containers are properly placed into the automated drug delivery system. So the law allows for the pharmacy, in conjunction with the facility, to determine who can stock the drawers or the unit dose into a drawer, depending upon the different type of automation. And in your materials, you mentioned that there's confusion out there and that nurses are currently stocking. It can be argued that even before these changes that took effect just a few days ago, that nurses could stock according to these policy and procedures in conjunction with the PIC. Omnicare certainly does not have any facilities that it services that uses nurse restocking due to the confusion that we're talking about today, but your own meeting notes say that other companies are engaging in that. I also, in my last minute or so, would like to say that in 2012, we specifically allowed nurse restocking in Idaho, and we have never had an issue with that. In fact, the Idaho board believes that it has actually been a move that increases public safety. We've seen a decrease in the use of tackle box type e-kits and an increase in the use of these ADS machines, as we refer to them in Idaho. And these machines, as we heard earlier today, have significant tracking as to who loads it, who has access to it, who eliminates it. If there is diversion out of one of these machines, it is very apparent as opposed to a tackle box type situation. So we do believe that this automation is best for public safety, and we believe that the law currently allows nurse restocking. And if the board doesn't believe that, I think it's a matter at hand. I don't think it's a future discussion and full day meeting. It is a matter at hand, and the board needs to at least put out a statement with their belief, because people that just read the plain law will think that it allows nurse restocking without understanding potentially the impact of different law that Ginny explained earlier today.
I think that's item 2 on the agenda, right?
That
The
is
nurse
item 2.
restocking. I think we're going right now on presentations regarding options available.
I jumped the gun.
Yeah, so that we're,
You just couldn't
it was
wait to
nice
get
to
up
hear,
here.
definitely.
We've actually had another speaker, though, that crossed over, too.
I will stand for
Thank you.
questions or leave the stand.
Thank you. Next, we have Cubics, I think.
I don't know if that's what you get for writing on the back of paper.
Oh, here. I don't know. There, yes. Karen Nishi, Cubex. You represent automation then? Okay.
Yeah, that's the agenda item we're looking at.
Good morning. My name is Karen Nishi. I'm a pharmacist, and I represent the automation company called Cubex. We make automated dispensing systems. We actually use Pyxis hardware, but program it with Cubex software. We are currently in the state of California in care settings outside of acute care hospitals. And we are being used in nursing homes as e-kits and emergency drug boxes. So in long-term care facilities, these facilities have emergency drug kits similar to this tackle box. So emergency drugs are filled in the tackle box at the pharmacy. This tackle box is filled and checked in the pharmacy and initialed by a pharmacist. It's then sealed with a zip tie in these holes and placed in a sealed tote. That tote is shipped to the facility, the long-term care facility. The manifest is signed for acceptance, and the tote, all the contents are put away by the nurse that signed the manifest or the assigned individual, so that the e-kit is filled and stocked, it's restocked in the pharmacy by a tech under the direct supervision of a pharmacist. So the automation system that Cubex uses is actually a QB system. So we use this for emergency drug boxes. So we have an automated box that sits out at the nursing home filled with these things called QBs. QB is filled, programmed, assigned to a facility, assigned to a box, it's barcoded, and then the chip is programmed, all in the pharmacy. There's a chip on the bottom of every QB, which is programmed so that when the QB gets to the particular facility the tote is open and signed for, a nurse or an individual with authorized access can log on to the box, the Cubex box, and place the QBs in it. If a wrong QB gets to the wrong facility or box, the QB will not set. It sets on a MOAB board, on a motherboard, and when the data is transferred, it'll realize that that's not the right QB, and it messages the pharmacy, but you can't set it in, so that you have to close the drawer because the QB won't set. So that is our technology. We've been in use under the Pyxis brand. I think I met with your board back in 2009. I actually worked for Pyxis. And we went through this process, and they said, okay, it's got removable pockets or drawers. It can be filled, checked, all in the pharmacy under the direct supervision of a pharmacist, shipped to the facility, and placed in the unit by the facility staff using policies and procedures. The board has now put in an application where you have to state where these systems are, and I think that's great because probably even I don't know where every single one is unless I looked on our Excel files. But I don't want regulation to actually prescribe how we have to practice as pharmacists, who does what. There's already a recognition in the law that these systems can have removable pockets, drawers, or containers. We have chip technology, barcode technology, and fingerprint technology. So if it's required that a nurse can't put this away, are you going to require that this physical tackle box that's filled, sealed, and checked in the pharmacy, put in that same tote, signed for, and when the nurse opens it, would actually a pharmacist or a tech have to take this out, unlock the medroom, and put it into the medroom? Because it's essentially the same thing, only there's only one drug for the e-kit, or a few. It's not a whole box, so that the process would be interrupted and different, that a nurse would not be able to put this away.
I think we're at the 5 minutes. Just one question, are those tamper-proof, the little cubies?
Yes.
So if someone does tamper with it,
Tamper evident.
you won't be able to put it inside the cube, inside the chip?
It won't set.
Okay.
It'll disable it. Thank you for your time.
Thank you.
Jenny, in days gone by, there used to be regs regarding how many different drugs could go into an emergency kit in the quantity. Are those still in place?
Yes, they were increased about 4 or 5 years ago, maybe even a little longer ago than that, to basically make a portable pharmacy. There's a lot of dosage units now you can have in there. Christine, do you know what I don't even know what it is. It might be 64 drugs with 4 doses of each or something. Pardon me? 48 drugs, okay, well, I was working on it. With how many different? Up to 16 doses. Okay, so 16.
Rob, you might as well come up here.
16.
Rob, I know you want to give public comment. You might as well come up since part of the discussion as well.
Thank you.
I bet the overall math was similar, but
That is substantially more than
it's
days
a
gone by.
it's a lot of dosage units. It's
And
a
I think
big
we're-
tackle box,
I think
too.
we're going into item 2 now. And are there any other automation companies, though? I think that's all that's signed up. So if not, we'll go into item 2, which is discussion and consideration of refilling of ADDS in skilled nursing facilities. In skilled nursing facilities, these units are sometimes installed, as we've heard, to permit furnishing of emergency medications or also to start initial doses to patients receiving care. The board staff believes that California law directs that since the undispensed drugs are the stock of the pharmacy is responsible for restocking the device, pharmacist intern, or pharmacy tech under pharmacist supervision. However, some skilled nursing facilities have begun using nursing staff or perhaps other employees to refill the ADDS. California Department of Public Health consultants and board inspectors note that the refilling of an ADDS is similar to restocking of the emergency kits in the SNFs, after which a medication is removed from a kit, the kit's returned to the pharmacy for inventory, restocking, and record-keeping functions. So I think that's the area where you wanted to make a comment, Rob, was in regards to the nursing home restocking. Is that correct?
Actually, I'd like to comment on some of the other statements that were made, just to clarify it from our perspective. My name is Robert Monet. I'm the Chief Pharmaceutical Consultant for the California Department of Public Health Licensing and Certification Program. As such, our program is charged with the overall licensing and certification of these facilities, such as skilled nursing facilities, and ICFs, intermediate care facilities. We also oversee general acute care hospitals where the ADCs or ADDs, however you want to refer to them, have been in existence for some time. I just want to clarify several points. In general, to our knowledge, and certainly in our regulation, and we're not aware of any authorization in pharmacy law that allows anyone other than a pharmacy personnel to restock these devices. That is being either a licensed pharmacist, an intern pharmacist, or pharmacy technician under the direct supervision of a pharmacist. 1261.6 is Health and Safety Code law. It was promulgated, I believe, in 1999, 2000, with a number of revisions since. I want to acknowledge that the technology, automation, and so forth has evolved tremendously since when this statute was put into place. I also want to acknowledge that my personal opinion of Health and Safety Code 1261.6, how it is written, it is confusing and awkwardly worded and subject to interpretation. However, given that, what we have to do, we have to turn to those that in this instance, with regards to restocking, in our discussions with the Board of Pharmacy, it's our understanding that the medications that are, regardless of what they're in, if they're in a cube, a drum, whatever you want to refer to it, that is not patient-specific, in other words, has not been dispensed by the pharmacy, remains the pharmacy's inventory, and therefore is to be under the control of the pharmacy, meaning the pharmacist ultimately. So given that, we believe that sections G, 1 through 3, that have been various and sundry interpretations therein, really refers to the integrity of the drug distribution system. It's talking about what needs to be in place on both sides to allow to ensure ultimately patient safety and that the medication is used properly. There's no stipulation in there that states that anyone other than a pharmacist or an intern pharmacist or a pharmacy technician may restock, under the pharmacist supervision, may restock these devices, and that's stated elsewhere in 1261-6. That said, we defer to the board's interpretation on this in terms of the position you're going to take as to who ultimately owns that inventory, who's responsible for restocking and so forth, and we will enforce and accord it accordingly.
And has CDPH identified issues that are going on where the pharmacy does not restock? Are there cases where there have been patient care impact?
We've had some of these issues over the years. They're isolated. We're not aware of where these devices are right now. As you know, there's no requirement for any of us to know until December 1st where these devices have actually been placed. So when we've encountered them, if the pharmacists are looking at them, they are seeing some issues in this area. I can't speak to the specifics of that, but it is a concern of ours. And I know that moving forward, because of the modification that's taking place in 1261.6, we're going to be surveying to these more closely. Certainly, as we know where they're at now, or we will know where they're at, we'll have access to where that information. So we'll conduct ourselves accordingly, as it states in 1261.6.
Thank you.
It sounds like that, being that it's the product or the inventory of the pharmacy and so on, in the event something went wrong and somebody got harmed, the liability would fall on the pharmacy. So if you have a nurse stocking, if I were a pharmacist, I would want to have the control if I have the liability. So unless they were to specifically authorize the pharmacy was specifically to authorize a nurse, I think there'd be some major problems with the liability part of it.
Well, if I just might add to, in terms of the analogy of the emergency kits, the tackle boxes, and they have been around a long time, those regulations are addressed in Title 22, been in place for well over 35 years. And they didn't anticipate then the needs or the technologies that would be in place that we have now. Just like we didn't, what was promulgated in 1999-2000 around ADDs, where the technology is. But there are very specific regulations as to, and limitations as to the number of drugs and the quantities, dosages they're in. They have to be in a sealed container that is tamper-proof. There's regulations also address what the nurse is to do upon opening it, who needs to be notified, that the kit needs to be replaced or restocked, but not by a nurse. Pharmacy personnel are able to do that, but usually what they do is an exchange system, one for one. That historically, that's what's done with those kits. And that is addressed separately, as I said, in Title 22.
And our council's advised, I think Laura just stated as well, that this has to be done under current law by a pharmacist.
Right.
Or under supervision.
So our interpretation, contrary to some of the pieces that I think you've heard, matches with the board's historical interpretation that only pharmacy staff can do the actual restocking of putting it in. And notwithstanding what you, G3 and how it's been presented to you, I would concur with what you've just heard, which is that the policies and procedures that the skilled nursing facility has to have address the policies and procedures about the other pieces, not specifically who's putting it in. And I've checked, Josh and I have had a conversation about that too, and he's on the same page. Under 4105, I think it is, of your law, the 4105.5, yes. The pharmacy remains responsible for everything that happens with an automated drug delivery system. So the pharmacy, as the responsible party, is responsible all the way through. And if you look at the rest of 4119, or excuse me, 1260.1.6, it does say the pharmacy shall be responsible for restocking. And it does have a provision for allowing what happens if the restocking occurs outside of the pharmacy. But it doesn't specify that the non-pharmacy staff may do that. And so Josh and I disagree with that aspect of it.
Thank you, Laura. And I think there's also a lot of variation. I agree with you, the technology's really advanced from when the tackle boxes were originally done. But there also is a lot of variation with the technology that's available. There's some devices where we just heard they've got a chip and you can tell whether it's been tampered with. But then on the other hand, you have others where the medication's just brought by a wholesaler or by the pharmacy in a Ziploc bag, and somebody's placing it in there. So there's a lot. I think we need to understand more of the technology.
UPS mail system.
Yeah, or UPS mail, yeah, and that has its own issues if it's pharmacy stock.
Well, the tackle box industry has certainly dropped the ball on its evolution.
Yes. An automated tackle box is what they need to come up with, right?
There was an opportunity there.
Thank you, Rob. Yes, public comment?
I have a question. So if a manual tackle box sealed with zip ties is filled and checked in the pharmacy and sent to the home, would a pharmacy staff member have to put that away? Because essentially, with a QB system or a system like that, yes, the drugs are the pharmacy's, but we're doing an exchange. So the box is filled, each QB is filled and checked in the pharmacy and then shipped to a facility and then put away. So would a manual tackle box...
Pardon the interruption. Your conference contains less than 3 participants at this time. If you would like to continue, press star 1 now, or the conference will be terminated.
So in the same vein, a manual tackle box, the drugs inside, filled and checked, sealed in the pharmacy, shipped to the facility, a nurse or an individual puts that box away for storage.
And they're different issues too. You're dealing with 2 different regulations, one dealing with skilled nursing facilities, the other with emergency supplies. And so I've focused more on the skilled nursing facility in that aspect, but I think it's a different issue. It doesn't change, though, my opinion.
Are you still going to have an automation day?
Yeah,
That was the intent of the board.
I think that we passed that motion already. We instructed the executive officer to do that. I think it's going to be important to look at all the different pieces of automation so we can look at what protection and safety pieces are to consider for future. And this would have to be legislation, right?
Right.
Is it-
Then can we hold on this and then have an automation day?
Hold on what?
Because you're just right now gathering information, or you're going to make a recommendation to the board, is that correct? On who can restock?
I think we already defined who can restock per our attorneys, that it can only be done by pharmacists or under pharmacist supervision.
Under current law.
Yes.
So we would have to change the law.
Okay, thank you.
And we'll have the automation day to
Identify what pieces
identify
are
what-
there.
what we
Yeah.
want to do, right?
Because we could put some, like it has to have a tamper-proof container, or there's a lot of different things we could add to that, and barcoding that we could include and update that law. Okay, any other public comment? Yes? Good morning.
My name is Jim Santon. I'm a long-term care pharmacist in Vacaville, California. And so I've definitely heard your interpretations today, but I would like to urge the board to look at the technologies that are becoming available today that can and do allow me, as a pharmacist working with remote communities in Ukiah, Clear Lake, where sometimes when I talk to my fellow pharmacists in Southern California, they say, where is that? They don't even know where those locations are. But this technology allows me to give a better quality of care, I believe, to residents in those remote locations, and it allows it to happen in a fiscally responsible manner. I'm a small organization, and it is possible that if I had to send a pharmacist out to Ukiah or Fortuna or Clear Lake, it may create a fiscally irresponsible situation that I could not afford to offer, in my mind, a better quality of care.
And just to clarify, I don't think it's a pharmacist. They can send a pharmacy technician, but it's under a pharmacist supervision. So it doesn't have to be a pharmacist. Just want to make sure that was clear.
Yeah, the key here, and I think what's missing is that it's the pharmacy that is actually restocking, not
Even a tech, it may not cut that mustard fiscally. Currently, my delivery people would take out any and all tackle boxes and other things to the facilities involved. And so I become concerned when I think about having to increase or double my costs possibly. I would just urge an open-minded consideration. We've stocked we do use some QBs, we use the Cubex technology, but there's many out there like that. And I presented to the board a few months ago when I was considering this because of my remote locations that I had. Right. And so we do have our staff take those secured totes out to the facilities, but they are not technicians, no.
They're your staff.
Correct. We hire those.
I think we're gonna do
We
some
hire the
scrap
delivery person to take them out. And certainly the interpretation of that law has been questionable or confusing in my mind.
And I think we believe that the law does need to be updated. We just have to go through the motions to make that happen. Because what's happened, I believe, is that this has been going on, I don't think the board was aware, but the board staff, and as a result of this new law where you need to register the automated dispensing cabinets, it's now come to the light. So we need to address it, and I think we're taking action to do that.
Correct. Correct.
Thank you for your comments.
Thank you.
Good morning. Good afternoon already?
I was
Almost.
checking. I was
Not yet.
I had my doubts.
11:52. Paige Talley with the California Council for the Advancement of Pharmacy, and hopefully this is an easy question. I just want clarification that, or to you to say again, that a pharmacy technician can actually take the drugs that have been filled at a pharmacy for the ADDS to the facility and put those back in.
Under direct supervision of a pharmacist.
And direct supervision would be?
So that the pharmacist is aware, there's actually a definition in our law, which I could find my law book, so that the pharmacist is fully aware of all the duties being performed by the tech.
So
there's a definition in our law of what
So
direct
the
Pharmacist doesn't have to be there with the
would have
tech.
to accompany
It would have
the
to be a
tech?
camera, there would have to be some means
So
by
they
which
can't-
that occurs.
But it could be a camera, so they could put a camera at the ADDS.
No, but in the case of the QB system, if a pharmacy tech were to put it in, they would know remotely that was actually, the pharmacist could monitor that remotely. They wouldn't have to be there or have a camera for that to happen.
Direct supervision means the following. This is in 4023.5. For the purposes of this chapter, direct supervision and control means that a pharmacist is on the premises at all time and is fully aware of all activities performed by either a pharmacy technician or intern pharmacist.
So the title of this discussion has been restocking the facility ADDS at the facility, but actually, when it's been mentioned that a pharmacy technician, an intern pharmacist, or a pharmacist can restock, it's taking those removable drawers or cubbies to the pharmacy, and that's where the pharmacy technician can restock under the direct supervision. So it can't be that they put them back into the ADDS, even if they're secured and tamper-proof.
I can't answer that. All I can do is rely on what our attorney said. I don't know, Laura, if you want to answer it, go ahead. I'm not going to, I feel unqualified to go down that road.
I'm not
You
gonna
understand the
answer it.
question,
No, I
Laura?
didn't understand.
Yeah, I
the
didn't
question,
understand it
actually.
either.
Okay,
So-
Wants no work.
I think it's a valid.
Yeah.
it is. In the pharmacy.
In the pharmacy, and so your question is, can a tech take that QB while the pharmacy is open, go over to Stan's skilled nursing facility, and put the QB in the dispensing machine at Stan's nursing facility? That's the question. It's my understanding that has been a common practice. It has been acceptable to the board.
That it's, so you're talking about filling the QBs.
I'm talking about putting it in the machine.
Putting the QB in the machine, or the, whatever
So
the.
it's a little box,
facility.
it's a little box, Laura, that
We've
actually
been
can
seeing.
show that it's
Yes.
tamper-proof.
Whatever you want to call the gizmo.
A tamper-proof.
But the gizmo with whatever the pharmaceuticals are in it, going into
Into the main
machine
ADDS.
where it fits in the
Yes.
machine.
And
Yes.
the question, though, is under direct supervision, does it require the pharmacist to be able to watch the tech put it in the machine?
It has to be still under the control.
But if it's
Direct
remotely
supervision.
monitored, yeah, but if it's remotely monitored, and if I as a pharmacist can go into my system and verify that box A with the 20 drugs 20 tablets I put in there, I could actually tell through the system that it was remotely put in, wouldn't that count as oversight?
I think that would be sufficient,
It
and
should.
without
Yeah.
having specific facts, I wouldn't want to go elaborate, but I'm not, it doesn't concern me.
As long as I can confirm that the 20 tablets I dispensed in that container that's tamper-proof was put into that remote machine, and I can confirm that they went in there, that should count as oversight.
Yeah, because the QB is barcoded. Once the barcode gets read by the machine, it's telling, and if it's tamper-proof, what could go wrong? I mean,
Well, no, I agree with you. But however, Jenny pulled up 4023.5, the direct supervision and control, and it says, direct supervision and control means that the pharmacist is on the premises at all times. So, I mean, that kind of,
premises of the pharmacy or the premises of where the machine is?
Technician only technically exists within the premises of a pharmacy
Right.
itself, and the definition of pharmacy technician.
Another reason why we have to update the law.
That's why it's difficult to respond to this. But we have, we have opined, I will tell you that staff have opined that
It's
allowing
okay.
the pharmacist to talking remotely in a skilled acceptable, provided that the pharmacist is aware of what that technician is doing.
It's
Well,
analogous to
there's your
filling-
answer.
Yeah, well, it's
So they
analogous to
can,
filling
if
an automatic dispensing
remotely
machine on the
controlled.
floor.
But the pharmacist still
What's your
remains
answer?
ultimately responsible.
Done by
Right.
tech.
So whatever occurs, if there's anything missing, it would still be their responsibility.
There's your answer, and we probably will have to update the
So we'll send
wording
something
to,
Yes.
But they can, even if it's remotely,
yeah.
remote,
And it's a tamper-proof container.
tamper evident. Okay. All right, thank you very much. Thank you.
Thank you. Okay. So I think we've got I'm sorry, go ahead. Good morning.
one pretty quick. I wasn't planning to make some comments, but I think a great point was raised with a long-term care pharmacy that's based in Fresno, and wanted to comment on the part about e-kits and the limitations. And part of the challenges that we have as a long-term care pharmacy provider is that we not only have to follow the pharmacy regulations and rules and laws that are out there, but also work with the nursing facilities to follow Title 22 and all the nursing home regulations. There's just a few of those out there in California. The problem that we have is, you mentioned, what are the limits that we have under the pharmacy law? And 1261.5 says 48 items, 16 deep. And I think if you go on to read further down, it says, but if you're using one of these automated dispensing machines, those limitations shall not apply. The problem that we have is that those limits aren't really in harmony with the requirements under Title 22 under Section 72.377. So I think we have a really unique opportunity here with members from CDPH, this committee, and I don't know if there's an opportunity for the two agencies to work together to kind of harmonize those requirements and get everybody on the same page, because it is difficult, trying to follow both sets of rules, one on the pharmacy side and the other on the nursing home side, if that makes sense.
Yes, but I think you actually heard concurrence between the two agencies.
Right, but you're talking about the loading. I'm talking more about the limits on quantities, the numbers.
And part of that may be the conflict. Usually the later enacted statute takes precedence, but I don't know, that may be another topic, and maybe there's a whole area of these issues we need to resolve. Title 22 hasn't been revised in, what did you say, Rob, 35 years? That is like amazing, that anything's still sitting out there untouched for 35 years in this space. But that may be something we have to talk about down the road.
Like I said, just something for consideration if this, in fact, is something that's opened up. Like I said, I think it makes some sense to look at, given that there is some change going on. Thanks.
Thank you.
Thank you.
Who do you represent?
A long-term care pharmacy called ElixRx.
Thank you. I think we've got a direction to go, and we'll schedule this one-day forum, and it's going to be focused on automated dispensing devices that are outside of pharmacies.
Right, we'll list the requirements of what the law provides for, and then we'll ask people to come in and talk about various things, how they're going to control it, how they're going to assure the right drug gets to the right patient, what kind of security features are there, who can stock it, the whole bit. We'll just kind of throw out a series of questions, and then we'll frame the discussions around it so that instead of diverse presentations, they will be more or less consistent and framed around these questions.
So what's the best way to reach out to the community of vendors that are out there? I mean, there's some that are presented here. Do we have a list, or what's the best way to?
Well, we will send it out on a subscriber alert, and I think that the people in the room may well know, in the past, they have found us when we've offered the opportunity to provide presentations. So we'll send it out early so that we can have the widest possible assortment of providers.
Steve Gray from Kaiser Permanente. On that subject number 3, what are the next steps?
What are we going to do?
Where you are now. I would suggest that when you set this up, there needs to be a clear distinction between ADDS-type devices that are used in conjunction with a skilled nursing facility, long-term care, et cetera, versus one of the presentations you heard where it was being used in a licensed clinic for dispensing to patients who take the medication home after they've seen the nurse practitioner or whatever. And the reason that's very important now is because the law was recently changed to allow a registered nurse who is working in a licensed clinic to do the dispensing instead of a physician or a pharmacist, et cetera. So it would seem to me that the board would want to consider facilitating where a pharmacist will be involved, as opposed to now, in those clinics, the nurse basically can take the drugs that are in stock and belong to the clinic as a licensed clinic, and upon a prescriber's order can go ahead and dispense them as though they were a pharmacy. And what inhibits a pharmacy being involved is just what we're talking about, which is allowing a pharmacy to remotely handle that dispensing process. And there's a lot of experience you could gain in both of these areas, perhaps by talking to some other states. Having attended in Washington State, for an example, they have a lot of remote clinics that are only open 4 hours a day, a town of 500 people, et cetera. Maybe even reaching out to some of the board members there or people with experience Because I think it's something that we do want the pharmacist to be involved, whether it be by two-way video or, 3D holograms, I don't know what's coming next, but rather than just turning it all over to registered nurses to do dispensing. And that was taken out of the board's hand as a separate statute, where these clinics said, we've either got to hire a pharmacist or we've got to hire a physician to do the dispensing. And so what they did is they came in and changed the law in California that said if it's a licensed clinic, an RN can just bypass the pharmacist and go ahead and do the dispensing. So I think we need to keep the two separate and talk about the whole concept of how do we make sure that the patients are getting the best pharmacist care they can get.
And I think Steve raised a good point, because I think there's two types of automations. We're doing one where we're restocking devices, where we're interfacing with a nursing home or a facility. The other is we're restocking devices or interacting where it goes to the patient.
Right.
So we may want to, it sounds like the most pressing one right now is the restocking of the devices in a facility. Isn't that our most concern?
Well, that's one that's causing the pressure out in the field, yeah.
But I think we probably need to make that distinction as well.
Yeah, I think it's probably valuable.
Okay, moving on to item E, discussion and consideration of possible regulations regarding patient enrollment in automated refill programs for prescription medication. Traditionally, pharmacists have refilled prescriptions only upon the request of a patient or a patient's prescriber. However, in recent years, there have been programs, automated refill programs or auto refill, that have come up, and these programs automatically refill prescriptions before the patient runs out of medication. And in most cases, these are limited to drugs that are identified as chronic care or maintenance medications. The benefit of these auto refill programs is to impact patient compliance, because the patients will, the belief is if they have access to it and they have a supply, they'll take it. Some of these programs have had adverse consequences for the public in that they have contributed to medications errors, waste, and fraudulent billing practices. There were allegations pharmacy staff enrolled patients in auto refill programs without their knowledge or consent because the pharmacists were working under work quotas that directed or rewarded patient enrollment in these programs. There's some statistics in the summary that's in your packet regarding the board's complaints from 2012 to 2013. And I think that's just been, have we had any more recent complaints, or is that pretty much all we've gotten?
We get occasional ones, but there was an LA Times article that generated that large flurry of complaints with auto refill because they ask if you've had problems, contact the board, and it was amazing how those 100 climbed real fast. We haven't asked any further assistance in that area. And CMS has also changed their requirements, and so we believe that that's kind of helped a little bit.
So in the prior committee meeting, we discussed requirements for pharmacies to retain signed documentation that patients have opted in to the pharmacy's auto refill program. The items that the committee had under consideration are how often signed consent should be obtained and whether the signed consent should be obtained separately for each prescription that the patient's placed on for auto refill. With regards to pharmacies in the community practice setting, additional requirements to notify patients upon pickup, both verbally and in writing, on the receipt if the prescription was refilled automatically. So when the patient picks up a medication, there'll be some notice to them that this was refilled automatically. Whether the above requirement should be documented in writing by the pharmacy. With respect to both community pharmacies and mail order pharmacies, consider requirements for written policies and procedures related to auto refill. For example, the policies might include procedures to ensure that any medication that's discontinued is removed from the auto refill program and that a drug therapy review is conducted by the pharmacist to prevent duplicate therapy. Committee members supported a motion for the board staff to develop an analysis and presentation for the next committee meeting and also to draft a policy for evaluating options for authorization and maintenance of auto refill documentation in community and mail order pharmacies. So a copy of the draft policy on audit. Now, is this a policy or a potential regulation?
Well, it's an actual policy here, and from this, the components in the policy would be used to draw up a regulation.
So that is attachment 5 in the packet.
The the draft policy on
Attachment 5. I just had a couple of things on here when I reviewed it, is in the beginning, when it says a retailer or mail order pharmacy may only use a program, do we need that word only? Because it's not going to,
No.
no, I mean, may use a program, right? We don't need the word only. And then under item 3, the pharmacy shall have safeguards in place that ensure only medications that are eligible. That's inferred that they've been approved by the patient? Is that what eligible? Eligible means that's been approved by the patient.
Well, something that's dose-dependent and they haven't titrated the patient to the right level, maybe that isn't appropriate for auto refill because you haven't yet stabilized dose. Antibiotics would be another example.
They would just keep a list of all the drugs that they consider eligible for auto refill.
It would be the pharmacist's decision. No, that's okay. I'd say it would be the pharmacist's judgment that would.
Right, and I think one of the things that Jeannie and I had a discussion about when we were drafting this was that instead of that word safeguards, we would want to put in the word policies and procedures, written policies and procedures, and we do allude to that later in number 9. But I think instead of saying safeguards, the pharmacy could take it upon themselves to write policies and procedures to delineate what's eligible and what is not.
Okay.
Safeguards is okay.
No, I think we should put
policies
written
and
policies and procedures.
Okay?
And just on the last one, in terms of the number 10, the pharmacy shall provide a full refund to the patient or the patient's agent. I would also say the payer, because if there is a payer, an insurance company, or some other payer that's actually paid for it, besides the copay, that should go back to them as well.
Yeah.
That's a good suggestion.
And then also that the patient, and then at the end, it says, the pharmacy shall provide a full refund to the patient or the patient's agent and the payer for an auto refill prescription that is reported as unneeded or none necessary if the patient or patient's agent can provide evidence or documentation that they did not register for the auto refill program, or I would say, or the patient notified the pharmacy of disenrollment as well, because they could also have said, I don't want this anymore, after they were on it.
I would make.
Is that okay?
My motion with those few corrections.
Thank you, Stan.
But I need a second.
Is there a second?
My go-to
I
guy
know, the
down
two
there.
of them are really
Yeah, I
good
know, it's
partnership.
kind of a
Any other
interesting.
board member comments on this? Public comments?
Oh,
Good afternoon.
I've been given copies of this language and I didn't distribute it.
I had to look at the time to make sure it was afternoon or morning.
Yeah, and I was handed the handout and I failed to distribute it. Sorry, Dennis.
That's okay. It's just so you have it.
Yeah, I've got it. Nobody else has got it, though. Well, hold on, let me find it.
Well, while you're passing it out, I'll get started.
Can you?
Because we're all getting hungry.
He's given us a copy of the law in
Texas.
Texas.
There's a significant amount of history with auto refill programs that really started about 2010. Dennis McAllister, representing Express Scripts in Arizona and a variety of other places. Been on for a long time, and early on, the complaints that were mentioned in your documents, both at the previous meeting of this committee and this one, are all true. The programs were evolving. They were not well-designed initially. Patients had difficult times opting in or opting out. The drug lists weren't matured to what's important for maintenance therapy. Well, over 6 years now, in the 7th year, they really have evolved. And the text before you from Texas was a result of the same complaints that were faced by the Texas board. Our company was involved in helping write these rules because if patients can opt in and they can opt out and they're in charge of their therapy, the company, the pharmacy, chooses the right drugs. You don't use warfarin or other things that have rapidly changing doses. It's a safe program. And not only increases adherence, but it also helps the pharmacy's workload balance. It actually gives pharmacists more time to take care of patients in front of the counter. So they're all very good. Texas rules came in 2014, and I'm speaking from our company's experience. In 2013, they had a lot of complaints about us. We fixed it all. Since 2014, no complaints. I'm thinking that you, not being critical, but coming in a little late to this. I think the programs have evolved, and it's happened in a number of other states. No other state, no, let me rephrase that. Most states haven't done anything. So comments about your proposed rules. Number 2, Texas actually recognizes some Schedule 4 and 5 controlled substances are maintenance meds. And so they put that in their rule.
Yeah.
Again, professional judgment by the pharmacist. Number 6, the annual review, I think, is unnecessary because the patient is in charge of enrolling or unenrolling. The complaints came from when companies auto-enroll people. Well, that doesn't happen anymore. So I think that number 6 probably is unnecessary. It's an onerous deal and could actually delay therapy. We're trying to get the patient to say, yes, I want this again. Number 7, CMS did address this. They actually tried to do a number 7 and pulled back because renewal of a maintenance med is simply a renewal of a maintenance med. Asking for approval to start again takes time. And as we know, in a company that does primarily mail, patients are hard to get a hold of. And so I think that would delay some therapy and cause some abrasion of the patients. Those are my comments. I think Texas rules work real well, give patients control, and it doesn't get the board into, if I may, micromanaging the programs.
I have one quick question on the, part of the reason that the one-year review is put in there for the auto refill is to make sure that the therapy over the course of that year hasn't changed. And if you don't have some trigger to periodically re-review it, especially if you're seeing multiple prescribers, you could have something that either duplicates the therapy or contraindicates the therapy. And so an annual review kind of requires a review of what the patient's taking. And part of the complaints that we did receive in that group of 100 were some where they got duplicative therapy from different pharmacies because no one was monitoring it. They just got re-enrolled.
I think that's something you should adjudicate or work on individual cases because a renewal is a renewal. And when you do a renewal, you have to do DUR. So I would say the pharmacists didn't do their job. So making the whole industry burdened with that, I think, would be excessive. It's a DUR issue.
As long as you're filling the prescription or you're adjudicating to the same insurer.
And unless it's a total cash pay patient, even if they go to a different pharmacy with a renewal, the PBM duplicate therapy is going to fire.
Okay.
So that's my response.
But that's why it was in. We had the specific discussion over that.
Yeah.
So most of the items you have on here, we already have included, except for this issue of the non-controlled. So I think you make a good point that there are some seizure medications and other controlled that are chronic care medications. So we may want to consider, and the pharmacy actually can decide that because it does say the pharmacy shall have safeguard that only medications that are eligible, and they can determine what that is.
Exactly, yeah.
Oh, those are my comments. And I think you're on track, but don't micromanage, be enabling. Build the guardrails.
Thank you.
You.
Any other public comment? And are you okay, Stan, with removing the non-controlled on here?
Yeah, I'm okay with that. I think that there are controlled drugs that are.
You okay, Greg?
Yeah, I'm okay with it, too.
And that,
I want to make
So we could say not a 1 to 3 controlled or whatever, but.
Well, I don't know. I think they should be specifically named in the policies and procedures because there's some decisions that are made. But I think, the reason that these drugs are controlled, they're controlled because of addiction potential. And so while some, like for neurological conditions, nerve conditions, et cetera, are definitely needed on a chronic basis. Some of them do, some others aren't really needed that way and can become addictive.
So number 3, Alan says, the pharmacy shall have, and per what Julie said, it's no longer safeguards. Pharmacy shall have policy and procedures in place that ensure only medications that are eligible are enrolled in the program. So the pharmacy would then determine that list, right?
I'm good.
Okay. Yes, good afternoon.
Thank you, Mark Johnston, representing CVS Health, but my NABP responsibilities extend to Oregon, so I keep a little closer tabs on what happens there. Oregon's had, over the course of, well, since 2015, these very same discussions. I agree with everything that Dennis just said, so I won't rehash what he said or even visit your draft language, which is ever-changing and a little hard to follow from the crowd. What I would like to say is that Oregon did pass a set of rules that were not just establishing boundaries, but micromanaged how these programs were to be run. And a legislator, after reviewing several studies, which I could provide the board, that show the benefits of auto refill to public safety, and comparing it against the very small amount of complaints, 100 complaints in a few years in California, I can only imagine the tens, if not hundreds of thousands of prescriptions that are auto refilled in your state, determined that the rule that Oregon came up with was worse for public safety than not having the rule at all. And he afforded the board the opportunity to revisit the rule as opposed to running a bill to override it. The board took that opportunity seriously, and they met with stakeholders over the case of a year. And just yesterday, the committee finally approved changes to the rules, which are very similar to Texas, which established some boundaries, such as the patient has to actually sign up. You can't be auto-enrolled and whatnot. Those rules will be going to their board on Monday, and then there'll be a comment period, and it'll be a few more months. But I guess I stand here to say that maybe you could learn from what happened in Oregon. Maybe Jenny could talk to Mark about the entire process, which was long and exacerbating, and I could certainly provide those studies that I mentioned on the value of auto refill.
So let me go back to the elderly couple I referred to earlier, if you were here then. You know, some of these people find themselves the recipient of these auto refill programs, and it is simply outrageous, the avalanche of things that come in the mail to them with the expectation that they take them all. I mean, I don't know what your experience is with CVS, but even the auto refill programs at your community pharmacies sometimes get a little out of whack with people who don't know how to stop it, who are constantly being called to come and pick up their medicines, some of which may have been deceived, but it becomes an avalanche of drugs to people who really have no defense. And what do you tell these folks? What does CVS tell their patients with regards to stopping the auto refill program? I mean, you can hardly get, at any of the chains, an opportunity to speak to anybody on a consultation, let alone trying to stop these auto refill programs. Have you experienced that at all?
It exists. I agree with you, Stan.
I mean, it's simply
Very much so.
outrageous, and you're sitting here saying that what we're contemplating doing might cause greater problems for them.
I'm sure there wouldn't be a problem.
Thank you.
I think it also gives a false sense
Glad
of
you resolved
adherence.
that.
It gives you a false sense of adherence because you think the patient's taking the meds and they're thinking, what is this coming for? I didn't order this.
You know, the physician says to the patient, take half a pill. It's impossible, practically, for somebody who isn't well-versed to get that change on their prescription without having, at least twice as much of their blood pressure pills that they need and pay for, and find themselves in the donut hole.
Madam Chair, members of the board, if I may, some of the boundaries that Oregon has in their draft that is now approved are opting in. There's no auto opt-in. It's opting in per drug, not just anything that might come across your profile. And it's immediately discontinuing. The company must discontinue if the patient or the prescriber says to discontinue that drug in the auto system. I think, as Dennis explained, that these systems have evolved over time. All of those provisions are part of the CVS Health program. The regulation that Oregon is proposing is simply what our system already is. So I think a lot of the stories that we hear of drugs showing up that weren't wanted or weren't ordered or aren't to be continued are older stories. They may have been true as recent as 2015, but there's so many changes to these programs that have been made across the industry, not just at CVS.
Are pharmacists encouraged and rewarded for auto refill enrollment?
Not at CVS.
There's no metrics that they're tracked and they don't
But
get a
that's-
bonus.
That's not true at all organizations. I had personal experiences being harassed time after time to sign up for the program, and...
Yeah, because when I interview pharmacists from the chains, they tell me all the time, there's a metric that I have to keep, and I've got to get these auto refill programs up.
Not at CVS.
So I think it's a good idea to look at the Texas and Oregon, see what they've done. Maybe you could reach out to their, before, okay. Now, Stan, are you okay on the, also the guidelines? There was a statement on there that the patient has to auto-enroll every year, had to renew it. Do you think that's necessary?
I like the idea of the patient having an opportunity to
review it.
disenroll.
Want to slow down business?
Yeah.
You think so too, Greg?
Madam
I
Chair,
do,
if I may
because
on that point.
I'm on an auto refill program, and there's a medication that I've taken for quite a while that I no longer really need, and I keep forgetting to tell them, and I keep getting the refills. So I think a requirement that you opt in periodically is a good thing.
And if it's an expensive medication, it could bump you into the donut hole.
Yeah,
Where all of a
absolutely.
sudden, it really becomes a huge financial issue when you have people winding up in the donut hole and losing a pharmacy benefit.
A very
It
good
really
point.
is.
I think we should leave it in.
Thank you. I said enough.
Thank you,
Ma-
Stan.
Madam Chair, on that topic, if I would encourage the board to think about the delay in therapy that might take place. You mentioned some
Oh, no.
confused elderly folks
Won't be any.
that may not be timely.
Elderly
and-
folks are the people we're talking about here. And so the delay of therapy, let's not go into that. We all understand that. We
I
don't want to make the
still-
same mistake Oregon did. We've been well warned on that. But,
An annual opt-in
No, this stuff.
is not going to mess up anybody's therapy.
Amy, can I just make a quick comment? When staff drafted this language, the Oregon law was looked at, as well as the Texas.
Oh,
And in addition, the CMS policy that we discussed at the prior board meeting.
Perfect, okay, thank you. So just so I understand, so those are guidelines, so they're not going to be regulations, are we going to go to the board and say these are because if they're guidelines, you can either follow them or you don't, and you decide.
We thought instead of drafting a reg to bring to you today, we would do a guideline to show these are the components that we think that should be in a policy involving refill meds. From that, we actually intended to draft a regulation to bring to the board, which is what we were asked to do. And we would do that at the January board meeting, because we now have a pretty clear discussion of where we're going.
So can we, now that we have got kind of the policy for the reg outlay, can we work on a regulation that we can bring before the board for approval?
Right. I think,
Okay.
I think we're pretty
Other
close.
Committee members, what do you
So
think?
directed.
Okay,
That was going to be my recommendation too, but I was waiting for you to finish.
yeah, the guidelines won't do us any good without the reg, will they?
Nope.
no.
Thank you,
Saying
thank
that.
you.
And they won't, by making them a regulation, they won't be guidelines, they will be requirements.
Right.
So
is that a
usually
motion?
Guidelines are permissive.
direction?
Yeah, that's a direction.
That's a direction.
Okay, direction.
And
Okay, got it.
Julie, thank you for the comments about Oregon and Texas, because that, if you've already incorporated it, we've already looked at it.
Yeah,
Thank you.
I mean, I do want to go back and look at what he was discussing, that something's coming up next week that they're looking at. But I did go to their website and review the Texas, the Oregon, and the CMS information.
Thank you.
Perfect, thank you. Okay, moving on to item F.
Wait.
I'm sorry. Oh, yes, I'm sorry.
So-
Oh, yes, we have a motion out and a second.
And as I understand it, the motion is to approve the policy.
The
and
draft
sort of-
policy.
And what will happen from there is that staff will take the policy and draft
Right,
regulation language.
But we are
present
going
to
to
the
leave
board.
out the controlled substance.
Yeah, we're going to remove the controlled substance off there. That word non-controlled will be removed off the beginning.
Right.
Okay. And it'll be up to, and we're going to change the safeguards with policy and procedures.
Policy and procedure, and you want number 3 completely deleted. Is that what you're saying?
Number 3.
No, that was
no.
controlled
two.
substances.
No. In the first paragraph where it says non-controlled, we're going to remove that word non-controlled.
Got it.
So it'll be up to the pharmacy to determine what they feel is safe for auto refill.
Okay.
Number 2 repeats it too?
Yeah, it says
Okay, wherever
prescription, not a
non-controlled
controlled
is, yeah.
substance.
Yes, two will be.
Yeah. Okay. Okay, we have a motion and we have a second. All in favor? Okay, motion carries. Thank you. Item F, which is a discussion and consideration of the National Council of State Board of Nursing, Nurses e-Notify system. The board had heard public comment from the e-Notify system during a prior meeting and expressed interest in learning about the system. We'll have an opportunity during this meeting to learn about the e-Notify system. The National Council of State Board of Pharmacy e-Notify system is a nurse licensure notification system that provides employers of registered nurses, LPNs, and LVNs with real-time email notifications about the nurses they employ. It alerts subscribers when changes are made to the nurse's record, including changes to license status, expiration date of licenses, license renewal, and public disciplinary action, resolution, and alerts. So are we having someone present this?
No, this is just for information. We were asked to provide information on what this program looks like, and so
There's no charge?
in the attachment, there is a brochure from the company, or the equivalent of a brochure.
So does the nursing board use this now?
The employers of nurses use it. I think the nursing board would be pretty much bound by the HIP data bank like we are, where they have to report this federally.
So is this something that might become a reality with regards to pharmacists and techs?
Well, if there is such an entity out there, individuals can actually, if I'm an employer and I want to make sure, and I'm a large employer, I don't just have 1 or 2 pharmacists, and I've got maybe operating, especially if they're operating in multiple states, I could go to the HIP data bank, which is the federal data source, and subscribe to that for my employees at $2, what is it, $2?
Yeah, a little over $2 a year, I think.
Right.
Well, not if you don't know and you're not certain what that individual may have been doing. It just provides insurance. For us, we have tried in the past to get ongoing reports from all of our licensees, but the cost at $2 per licensee per year is pretty prohibitive. So we have 140,000 licensees. You can see already what the math looks like. So we rely on the arrest reports that we get when people get arrested because we fingerprint them. And so we use the convictions and the arrests to do our discipline. And then we have the further requirement that each licensee at the time of renewal now certifies under penalty of perjury that he or she does not have any convictions or arrests that we don't know about. So by that, we actually are kept apprised of what's going on with individuals if they are licensed in multiple states. That plus we do get periodic information when somebody takes discipline in another state. We share.
This is just informational.
It was asked to be informational, that's what it's provided for, and there may be some employers in the room that would want to use the HIP data bank for a similar service so that they can keep aware of what their individual licensees are doing perhaps in other states.
And the Board of Pharmacy submits data to the HIP data bank, so they can still
We're
access
required
this.
to.
Okay.
And who asks to put this on?
Who asked to put,
I believe it was Dr. Gray.
Oh, okay.
He mentioned the fact that the nursing board had it at a previous meeting, and so the staff went and investigated it just for information.
so that's all it
Nursing
is.
board. And we want to imitate them?
Did you read the auditor report?
Oh,
Did that slip out?
The 60-page report? No, I didn't see
Oh,
that.
God, I got a trip to the director's office on that one.
Okay, any public comment? Okay, item G, discussion and consideration of possible revision to Title 16 California Code of Regulations 1707 on off-site storage waiver, and this is to address licensees with previous record violations. So existing board regulations require that pharmacies retain records of all acquisition and disposition of drugs for at least 3 years. Most of the time, most pharmacies do use off-site storage requests or off-site storage to store records. The requirements for this is specified in Section 1707, which is in Attachment 7 of our packet. However, the regulations, the way the language is currently written, is that only licensees that have no record violations are eligible for an off-site storage waiver. In 2015-16, the board issued 178 off-site record storage waivers and denied approximately 10. So what the board has identified, the board staff identified that pharmacies that are cited, then they want to go enroll in it, can't because the law says you can't have it. It's like the chicken or the egg, which comes first? And we're really penalizing them. So the request is to modify 1707 with the language that's proposed where it says, it removes the whole area at the very end where it says, unless the applicant has, within the preceding 5 years, failed to produce records pursuant to Section 4081 of the Business and Professions Code, or has falsified records covered by Section 40081 of the Business and Profession. Do we really want to remove falsified records? Because that seems very different to me than someone who has a
We would
storage.
still deny for this, but sometimes the way that it was worded, it prevented us in these cases where we went out, we did an inspection, the pharmacy had already moved the records off-site, and then the end result was they had to move the records back into the pharmacy because they...
Approve it.
Right. So this gives us the discretion to approve them or not. A falsified record is a whole different thing, and generally, a falsified record to us is going to be a pretty serious violation that we pursue anyway, because that's one of the core things that we use to enforce around.
So I think the other thing that was changed is instead of the word shall
Is the
grant
may.
the waiver is may. So
Yeah.
that gives you the
That's where the
ability.
discretion piece comes in? Yeah.
So it's staff recommendation that so we'd have to open a rulemaking. on
Yeah, we'd
this.
have to do it with
So we
the-
would send it to the board with this recommendation that we adopt this change
Yeah.
to section 1707. Is there a motion? Greg, second. Any public comment? Good afternoon, Steve.
Hey, we made it to the afternoon.
Steve Gray from Kaiser Permanente. I would also suggest a consideration in your motion or in your developing going forward, clarification, since you're going to open up this regulation for a modification anyway, there's been a considerable confusion in the past what off-site means. In other words, we've been told by supervising inspectors that I don't have to store all the records in the pharmacy as long as they're on the premises. And then, and so does off-site mean out of the pharmacy anytime I want to go, even if it's just the room next door to the pharmacy, which not part of the licensed area? So again, we go back to the issue that we've talked about before, where the use of the word premises in the code in three, at least different places, means different things. And so I cross-check about what this whole section means related to off-site versus premises, et cetera.
Premises means licensed area, and in B of 1707, which we're not changing, an entity that is granted a waiver pursuant to this subdivision shall, 1, maintain the storage area so that the records are secure, including from unauthorized access. We have seen one storage area of one entity that this actually came before me as an office conference matter, where they put the records back where their inventory is kept for the whole store, not just the pharmacy, but the whole store, and they said that that was protecting the records. Under B, it did not protect the records because anybody back there in that storage room could have access to the records.
Right.
So consequently, the premises really means the licensed area.
Yeah, that's not what we've been told on several different occasions over the years, and as you know, I go back a long time. So my point is that rather than, if you're going to modify it, rather than say off-site, just say outside the licensed area of the pharmacy. Then it's clear that anytime you want to store records outside the licensed area of the pharmacy, then you've got to get the permit.
Does that make sense?
Yeah, I think that's a good idea, yeah.
Let's put that in.
Okay.
Can we modify that to your motion? You
Yeah.
okay with it?
Yeah.
Hi, Tony, come on.
Hello, Tony Park speaking on behalf of, I guess, myself. Another thing that you may want to consider, since we are revisiting this issue is the situations where, this happens quite frequently, where pharmacy owners, usually smaller independent pharmacy owners, when they decide to close their doors for good, they don't know what to do with the records. Because as the regulation as it currently stands, it says that off-site records, off-site storage waiver can only be obtained if you have an active license. So if the underlying business closes its business for good, and assuming that there's no subsequent sale or prescription file sale, what are they to do with the records? So something for you to mull over and perhaps give clarity on that issue.
The answer to that is, as you know, is that they have to be stored in a licensed location for a period of 3 years following the closure. That's so that we can access the records if something becomes a problem, if a patient needs to get to their
So
records.
this is another pharmacy they have to find that'll.
They have to find another
that'll be
licensee.
willing
It doesn't
to-
have to be a pharmacy, but
wholesaler,
generally it
if
is. It
you're
can be a
another
wholesaler.
pharmacy.
Right. Where we don't want them to go is to record storage or put them in their garage, which is where we also, where one of the preferred locations would be, because there, you don't know how those records are going to be protected. And those are your confidential health records, and there is no desire to have them just and I'm not, maybe cavalier is the wrong word.
Is that currently in regs that when they sell, they have to leave it with another licensed?
Yes.
It's not currently in the
Part of our
regulations?
discontinuance of business requirements.
Which was
It's already
great
there.
if the business is going to be sold to another owner, or if the file is going to be sold to a chain drugstore. But, and perhaps this isn't that big of an issue, but it definitely happens enough to make it worth your attention, where sometimes, unless you have a friend or somebody willing to take your records off you, you're kind of stuck with this kind of no man's land.
Somehow or another, they find a solution, but they frequently come to us, what can we do? But for us, it's a very big deal. Plus, I used to sit on a panel at the state, I've been around so long, I've done all kinds of stuff. One of the things was, the concern was that when things went into those record storage vaults that are all over the place, people would die and quit paying the bill, and then suddenly all these records would come up for auction.
Wow.
And there is a real serious problem, like what you do with those. And that is not just pharmacy records. Those are like real estate records, law records, things like that, where
So
you've got
they-
real sensitive information.
Are they required to notify the board if I'm selling a pharmacy and I've got records and I don't have anyone else buying it? Am I required to notify the board where those records are?
You file a form with us, and so we know how to get a hold of you, and we know where the records of that pharmacy are stored.
Look in attachment 7, fourth page or so, Article 20, under prohibitions and offenses, 4320 to 4343. Or 43.
Which number?
4343.
Well, it's actually 4333.
Okay.
States what happens what you need to do with records when you close down businesses and so.
And that's statutory.
So in conclusion,
Yeah, but $200, it may cost me more to store
Well, I
it
think we
than
may
the
want
fine
to
that
talk
I'm gonna
about that.
get.
We may want to talk about that particular violation, since we can now charge up to 5,000. But,
if at all possible, if there's a way to allow for some sort of off-site storage ability for the pharmacy, because in all honesty, what happens in real life is that they look around, they have no place else to put the records, so they end up putting in the garages or other bizarre.
don't tell us that. They have to
yeah.
file a form under penalty of perjury telling us where the records are. And if we saw one coming in with the garage, we're going to have a problem with it.
Fortunately, there's a
Says right
attorney-client
here
privilege, so I
that
won't tell.
records need to be maintained in a board licensed facility.
Right, any board licensed
Yeah,
facility.
but it's gonna cost you more than $200 to do that.
I'm sure it will.
So might as well just take the fine. So should we
Yeah, but
review this? and
I
have-
think we may want to consider this an omnibus provision if they'll consider it, and possibly
Fine
remove
can
it.
be assessed more than once, though, right?
Well, we could give them 30 days to fix it and then come back in, or 60 days or something. I mean, the goal is compliance. Again, the goal is not to ding our licensees.
I
The goal is
understand.
to
It's
protect the
get-
records.
Exactly.
But it is a real serious matter, because if you think about it, we all end up with records everywhere.
Okay, any other public comment? Okay, we have a motion and we have a second. All in favor? All right. I think we've got lunch here, right, Debbie? Okay, we can just, are you guys okay working through lunch? Just going through and continuing? Okay.
Break before the compounding.
Break
hours.
for about 20
Yeah.
minutes, 20 or
Before the
30 minutes.
compounding, yeah, let's just keep going.
Got all kinds of stuff going on here.
All right, I know. Item H, discussion and consideration of a possible amendment to New Business and Professions Code 4316 regarding cease and desist orders. It's a proposed amendment to this regulation. Last year, one provision contained in the board's sunset bill, with which SB 1193 provided the board with the ability to issue a cease and desist order to an unlicensed entity operating within the board's regulatory jurisdiction without a license where one is required. However, following the enactment of SB 1193, staff identified items in this provision that needed clarification. So there's some proposed modifications to BNPC 4316 included in your packet. The staff is seeking the committee's recommendation to pursue enactment of these modifications. So the first one is under, after the board, adding in through its executive officer, in terms of adding the executive officer the ability to issue a cease and desist order for operating any facility under this chapter that requires licensure for practicing any activity under this chapter that requires licensure without obtaining such licensure. That was another addition, is those words "without obtaining such licensure."
Okay. I move that we approve or accept.
Well, the other change, though, is on item C.
Yeah, I see.
Instead of pharmacy facility. So do we want to say, instead of facility, do we want to say, because it says maybe sought by the owner, person, or possession and control of the facility license, or should we say the facility?
It says facility up further above as well, so.
Does it make a difference if we say the facility or facility license?
They wouldn't be licensed.
If they're not in control, okay, all right.
Yeah, and we have a quick, so when we made these edits, we re-edited ourselves in one case, in this paragraph A at the last sentence. We actually were thinking that it might be more appropriate to say that requires licensure without appropriate licensure. And the issue there being that we don't want there to be an argument that somebody who started the process to obtain licensure is
In the
somehow
process.
in the process. So we're really talking about without being licensed. So the words obtaining such, we're recommending they be replaced with the word appropriate.
Is that the only change?
Appropriate license.
Correct.
Are you okay with that, Greg?
Yes.
Okay, is there a second to Greg's motion?
I'll second.
Okay.
But I have
Two
a
of you
couple
are.
questions.
I'm
sorry, did you want to second it?
I like the way, no, I like the way they work together.
There's quite a tag team going on here.
Dan?
So,
Yes.
is this, and I realized you get Stan's Pharmacy gets a cease and desist order.
Because you're not a pharmacy.
What?
Because you're not a licensed pharmacy.
Well, I mean, but it's something that you want to deal with immediately. Yeah,
Right.
I mean, this can't wait. But when we look at the administrative side, is this all practical with regards to the president and the vice president? That within 15 days, the facility may request a hearing before the president of the board, and then the hearing shall be held no later than 5 days from the date of the request. So if, I'm sure it's 5 working days, but still, I mean, the president and the president shall render written decision within 5 days of the hearing. In the absence of the president, the board vice president may conduct the hearing. My point
Dan,
is.
we've actually done this.
That's already there.
And I have also once.
No,
But the
you and
point-
I have.
Yeah, but the point is, I mean, when we have a volunteer board, and so many of us have other responsibilities, hither and yon.
But it's been here for a long time, hasn't it?
Well, for a year.
Okay, but I mean, have we had any problems with it since?
This particular provision actually was part of the Senate Business and Professions Committee recommendation for us. We sought initially a cease and desist order to be able to cite and fine for failure to do this, I believe. I don't even remember what triggered it. But in any event, this was the language they preferred. And what they wanted to do was to provide an immediate alternative that in the event we capriciously acted, that there would be a means by which
And if
they could address
If we
it.
find it becoming too burdensome, we can look.
We haven't used it yet, although we were going to.
No, we did use it. I
Right,
mean, there
we've
was
used it, so the language that's before, that was amended into the law mirrors the cease and desist provisions that the board previously had for sterile compounding.
Right.
And so what this does is it builds in a due process piece, because you're essentially telling someone they can't conduct business. So if someone appeals that, it was intended to mirror the cease and desist appeal provisions that are included for the sterile compounding.
Thanks, Ann.
And cease
Fair
and,
stand.
cease
Well,
and-
it's just, if it isn't problematic, or if it's got to be
Yeah.
what it's got to be, I understand that, but it's just great expectations of people and the flexibility of their schedules.
In the event it becomes a problem, I think we would be faced with one of two things.
Address it.
Is there another alternative? Do we modify the language, or do we just find some way to persevere?
Okay, it just begged the question for me.
No, fair enough.
I would echo the issue that you're facing with any kind of cease and desist order where you're telling somebody to stop doing what they're doing is a protected right and constitutional issue. So
And I don't want to
that's where
minimize
that's
that by
coming
one
from.
moment. Yeah. I mean,
Public comment.
My curiosity was really, could you delegate beyond the president and the vice president?
Oh, I see. Okay. Well, under the way it's written,
Probably could.
that you can't, because I think it's specific to those two individuals.
Any public comment? Okay, we have a motion and a second. All in favor? All right, item I, discussion and consideration of U.S. Department of Health and Human Services, FDA's article on Drug Supply Chain Security Act implementation. It was issued on November, I think it was just issued in November 2016, right? December
Yeah.
2016. The FDA published a guidance document that was titled Drug Supply Chain Security Act Implementation, Identification of Suspect Product and Notification Guidance for Industry to Clarify. And this is for manufacturers and other trading partners to notify the FDA if there is a high risk that a product is illegitimate. The FDA is seeking comments and suggestions regarding the document for a comment period that expires on February 7th of this year. The committee may wish to consider if the board should submit comments. The guidance identifies specific scenarios that could significantly increase the risk of a suspect product entering the distribution supply chain. And it provides recommendations on how trading partners can identify a product and determine whether the suspect product as soon as practicable. Are we having Michael do a presentation
Michael's
on
in the back
this?
of the room, or was? I don't, oh, he's up in the
He's in
front
the
of the
front.
room.
All right,
now.
Michael, come on up.
Couldn't we just send them our oldie pedigree stuff?
Yeah.
Very funny.
Thank you.
But yeah, I thought the same thing. I'm going, we had
How
more
much time,
extensive,
Michael,
we had more
how
extensive
much time do
information.
you need for the presentation?
5 to 10 minutes.
Perfect. Got it. Thank you.
Do you want to pass out the food and we can?
Yeah, let's pass it out if
Oh,
we
God,
can.
it's
Yeah,
like a
so we can
movie.
start.
Okay.
Should we give everybody a 10-minute break then, so that they can,
Yeah, let's do a 10-minute break. We can get Michael set up. So we'll start back up again at 1 o'clock. Thank you.
get my own alternative notice here?